Yes. So this is I can hand over to Cess.
Monica ma'am, can I share the slides?
This is Ma'am Ranjit Sahu, Head of Marketing with Walter Bushnell. Amongst Public Awareness Committee present World Breastfeeding Week, a symposium on breastfeeding. We have the eminent panelists all across for this beautiful webinar on this breastfeeding. With this, I hand over the session to Sachin to take it forward. Over to you, Sachin.
Thank you very much, Ranjit sir. I welcome once again all the esteemed faculties from the PAC committee of AMOX. I am Sachin Amte, RBM in Leadership Division of Walter Bushnell. Monica ma'am, can I share the slides? Can I start?
Sachin, you can start, please.
Ma'am, madam is I think not there, ma'am.
No, Saman madam is there. She will just introduce Pratibha and Saman. So Saman will carry forward. Don't worry.
Welcome all the delegates. I'm introducing Dr. Pratibha Baldava, ma'am. And she is the obstetrician and gynecologist and fertility consultant at SS Baldava Hospital at Solapur. Also, Dr. Pratibha Baldava is a gold medalist at DFP fellow at American College of Obstetrician and Gynecologist. She has introduced 12 international papers in Indian Health Journal, Hum Repro Science, Indian Obstetric and Gynecology Research Gate Chronicles ECT on the PCOS, AMH, and infertility related topics. Finalist of the Mahesh Ideal 2020, loves to write the poetry in free time. It's all about Dr. Pratibha, ma'am. Again, I'm introducing Dr. Saman Khan Tamboli, madam. She is the consultant gynecologist, obstetrician gynecologist at a Tamboli clinic. Also, she has a consultant and obstetric gynecologist at a Max multi-specialty hospitals at Solapur. Even she has an international board certified lactation consultant. So it's over to Dr. Saman, ma'am. Saman ma'am, you are on mute, Saman ma'am.
Hello,
Yes,
everybody. Good evening.
Yes,
we will now go ahead with lighting of the lamp.
We can't hear the voice.
It is very low, ma'am.
Sachin, it's not audible.
okay, ma'am.
Ma'am, should I make it once more?
Yeah, please play it again.
It's okay, Saman. Let it be. It's already 5:10.
Okay.
Can you share the next slide, please? Okay, now I would like to introduce Dr. Monica Umbardhan, ma'am. Madam is MD, DGO, FCPS, DFP, FICOG, LLB. She is consultant obstetrician and gynecologist at Mangalya Nursing Home and Atharva Fertility Center. She is PAC committee chairperson AMOX 2022 to 2024. She has been website coordinator for AMOX in 2018 to 2020. She has been youth coordinator of AMOX 2020 to 2022. She is executive member of PAC 2019 to 2022, executive member ICPAR 2019 to 2020. And she is very active in Solapur OBGY Society. And she has also delivered her daughter.
Thank you, Saman, for the kind words and
Ma'am,
an
please carry on.
introduction. Yeah. I would like to welcome each and every faculty today. I am honored to present Pardeshi sir as a chief guest and Mandakini ma'am as the guest of honor. I am really privileged that they have consented for the same. Please stop sharing the slide for a minute. Yeah. Uh, I would like to introduce the World Breastfeeding Week, which was from the 1st of August to the 7th of August. And this year, the theme is for let's make the breastfeeding work for working women. So today, with the help of Amongst Public Awareness Committee and our esteemed faculty members who are very, very active in promoting breastfeeding, most of them are lactation consultants. We also have Dr. Sneha Buyar, madam, who is the past chairperson of the Study of Female Breast Committee with us for her expert comments. I am indeed obliged that all of you have participated and accepted our invitation for this Amongst Public Awareness Committee webinar. I take an honor to introduce Pardeshi sir. He is currently the president Amongst. Can I have the slide, please? Not to mention that sir has always been there for each and every program of Amongst Public Awareness Committee. Sir, thank you so much for giving us a free hand, sir. The leaders are the ones who trust in the members. Unless and until you trust in all your chairpersons, sir, the association cannot go ahead, and you have proven that everybody can work together and reach greater heights, sir. I welcome you for this webinar, sir.
Thank you, Dr.
Kindly
Monica,
bless us.
for kind introduction. Good afternoon, everybody. Respected Dr. Mandakini ma'am, our grandma in all aspect. See, even if election is going on, now this is 9th day, but still she is active on academic platform. And we still remember her tenure as ICOG chairman with full of academics. Respected AMOG's office bearers, Dr. Sujata Darvi, Dr. Monica Umbardan, Dr. Sneha Boyar, and Dr. Charu Bapai, Chairman Foxy. First, I wish to congratulate our ever active, ever smiling Dr. Monica Umbardan, Chairperson PSC Committee of AMOG. She is very active, conducting programs regularly. And these are the pillars of our AMOGs. Hence, AMOGs is reaching height. So as all knows, the importance of breastfeeding, I don't want to go in detail because symposium that is explanatory to all that is going on. But the importance of breastfeeding that has been highlighted in all aspects in this symposium. In my opinion, breastfeeding keeps healthy to mother and baby also, and hence to the family and to nations also. As all are aware that breastfed babies, they have a lower risk of asthma, type 1 diabetes, and sudden infant death syndrome. Breastfed babies are also less likely to have ear infections and stomach bugs. Breast milk shares antibodies from the mother with her baby. These antibodies help babies develop a strong immune system and protect them for all illness. And I think this seminar, this symposium will explain all these things in detail. Dr. Sneha Bhoyar, Dr. Charu Bapai, and Dr. Mangala Wani, and they are the guiding force to this symposium. Just recently, I attended BreastCon conference in Pune, which was organized by Charu Bapai and Mangala Wani. It was a really academic and practical. With the galaxy of faculties like Dr. Alka Kute, Dr. Mangala Wani, Dr. Vandana Gandhi, Dr. Asha Nikte, Dr. Suvarna Bhopre, Dr. Alti Kulwal, Dr. Samman Tamboli, Dr. Pratibha Baldava, Dr. Mangala Rathi, Dr. Kundan Chopre. I think this is going to be a great event. Congratulations again to Dr. Monica Umbardan for this great event. Wishing every success to this event. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much, sir, for your kind words and blessings for this webinar. I take privilege in introduction of our guest of honor, Dr. Mandakini Madam. She's a mother figure to me, and she's always been there to help me. But to complete the formalities, I would like to introduce her formally as Chairperson ICOG Foxy for the year 2021, President of the Association of Medical Women in India with the Central Council, International Vice President of the Medical Women's Association Central Asia, the National Vice President of Foxy for the year 12 to 13, the member of the FIGO Committee of Infections During Pregnancy, and member of the OFOG in Reproductive and Sexual Health. Apart from all this, she is a great human being, and she has always been there to help all the Foxy members in every situation, whether it is MTP, whether it is FOXO, or whether it is ART law. We welcome you, ma'am, and we wish you all the very best for your elections, ma'am.
Thank you very much. Good evening to everyone. And you can see the pleasure and satisfaction at the faces of myself and Dr. Sneha Bhuya as we are approaching the concluding part of our elections. So I think Dr. Pardesi has said wonderfully that you can see it all. It shows a sense of satisfaction, that much I can say. So with these words, good evening to everyone. Honorable our President of EMOX, Dr. Pardesi, and Dr. Sujata Darvi, also our Public Awareness Committee Chair, Dr. Monica, ever smiling, ever efficient, and I think, falling short of words, ever efficient I can call, and she has organized all my Gyan Ganga series all throughout 2 years. So thank you, Monica, for being there. Sneha, my other Vice President when I was ICUG Chair, Mangala, crusader for the breastfeeding, you are the pioneer, and all the experts I can see here, then Dr. Mangalavani, Alka Kuthe, and Mangala Rathi, everyone, Dr. Asha Nikte, everyone there. So I think this is a proper time to organize such a webinar, because we are already celebrating breastfeeding week, and all over India and abroad, and as a WHO, we are celebrating it. I remember Dr. Fernandez coming to Kama Hospital when I was a superintendent of Kama Hospital. So that time the concept was, say, 30 years back. She said, Madam, we have to have the baby-friendly hospital. That time it started with the baby-friendly hospital. And in the baby-friendly hospital, one cause early breastfeeding, importance of breastfeeding, it was started to have the human milk banks, because human milk banks is also very important part of the human milk which is available to the mothers who actually cannot feed or the children. So the breast milk is a gift to herself, to the mother, to the baby, and to the earth. And it's not only the right of the mother to breastfeed, but it is the right of the child also to have the breast milk as their feed. As Dr. Pardesi and everybody is going to, I think, discuss that it lowers the immunity, it lowers the infant mortality, and it lowers and it develops the cognitive functions as early as possible. So I think it's a great initiative, public awareness, making the mothers aware for their breastfeeding is I think, great humanitarian work, I will say that. And you all are doing a very good work. Today's seminar, we have all the experts, and I think founders of breastfeeding, pediatricians also I can see. So I wish your seminar a great success, Monica, and everyone here, and have a great awareness for the public as well as for the obstetricians and the doctors. So thank you very much for inviting me, and hope for the best tomorrow. Thank you very much.
Ma'am, we wish you all the very best from amongst Public Awareness Committee. Sneha ma'am, we wish you also the best.
All the best, madam. Make madam all the best, Neha.
All the best.
Thank you.
Thank you, sir. Thank you so
Thank
much.
you, ma'am, thank you for joining us today, ma'am. Sneha ma'am, we are extremely thankful to you also to join as an expert. I spoke to Charu ma'am. She is in an emergency OT, ma'am, so she might join late. So can we start the symposium, ma'am, with your permission? I will ask someone to introduce all of them, and then we can start the questionnaire session.
Monica, I just forgot to mention Vandana because I was looking for a phone number all the time. It is coming, I couldn't contact you. So good evening, Vandana. I'm trying to contact you.
Ma'am, she's in the US.
I'm actually in Canada, but wishing very best wishes for Mandakini ma'am.
Someone we can have the slides now, and you can start introducing all our esteemed panelists so that we can start the symposium and the question answer discussions.
Yes. Sachin, can you share the slide, please?
Sure, ma'am.
Next slide, Sachin.
Start with Dr. Buyara Madam's slide, please. The next slide, please, Sachin. Yeah.
Ma'am, it's a Buyar madam slide only.
I would like to extend a very warm welcome to Dr. Sneha Bhuyar ma'am as our expert. Madam is MBBS, MD, FICOG, FIC, MCH. Madam has done her MBBS and MD both from BJMC and Sassoon General Hospital, Pune. She is managing director, Sukha Hospital, Maternity Surgical Nursing Home, Laparoscopic and Infertility Center. She has 29 years of experience in the field and a teaching experience of 5 years in SVN Government Medical College, Yavatmal. She has published many papers in national and international conferences. She has been the organizing chairperson of various conferences, including Lactacon in Pune 2019 and BreastCon in Pune 2022. She has won various awards and accolades, including the National Individual Award FOXY 2008 for outstanding work in rural obstetrics, Dr. Anandibai Joshi Award by Government of Maharashtra in 2005, the FOXY Appreciation Award for
my
Public
dear.
Awareness.
Thank you so much. That should be enough. Thank you.
Welcome, ma'am. Thank you for
The
joining
next
us
slide,
today.
please. Yeah. You introduced Charu ma'am. She said she will join once the OT finishes.
Dr. Charulata Bapai is consultant obstetrician and endoscopic surgeon. She's MD FICOG. She's director GEMS Hospital and Endoscopy Center and Ashwin Hospital, Pune. She's chairperson study on female breast committee FOXY. She's honorable consultant Dinanath Mangeshkar Hospital and Cloud9 Hospital in Pune. She has done her MD OBGY from BJ Medical College, Pune. She's trained in gynec endoscopy from Beams, Mumbai under Dr. Rakesh Sinha. She is also trustee of Bal Kalyan Sanstha, Pune. She is a recipient of Smita Zog Award 2019 for exemplary work in adolescent health and recently won the Women Entrepreneur Award through Rotary, Pune. Ma'am will join us later. Next slide, please, Sachin.
Is it visible?
Now I would like to introduce, yes, it's visible. I would like to introduce our panelist, Dr. Alka Kuthe ma'am. Madam is consultant obstetrician and gynecologist, president of Amravati OBGY Society 2008 to 2009. She has also done LLM in criminology and has a PG diploma in human rights education. She is the chairman of IMA MS Medical Legal Cell 2023. She has been national coordinator of FOXY Ethics and Medical Legal Committee 2020 to 2023. She has been IMA Mission Pink Health Regional Coordinator in 2016-2017, past President Indian Medical Legal and Ethics Association, past President BPNI Maharashtra, State 2006-2008. She has done a lot of work in the field of breastfeeding and she's also has been editor of the first textbook on medical legal issues and JIMLEA. Welcome, ma'am. Next, I would like to introduce.
Yeah.
Next, I would like to
Please go
introduce
ahead.
our. Hello, am I audible?
Yes, yes.
Next, I hope Dr. Alka ma'am, I'm
Yes.
welcoming you again.
Yes, yes, you are audible. Thank you very much for kind introduction.
Next, I would like to
Tamal,
introduce
please
Dr.
go ahead.
Mangala Vani ma'am. She has been the pioneer in encouraging breastfeeding. Madam is MD, DGO, DOBS, FRCOG, IPCLC, obstetrician and gynecologist and lactation consultant, director, Hirkani Gynecology and Breastfeeding, Medicine Clinic, Pune. She's consultant at Shashwat Group of Hospitals, past president, BPNI Maharashtra, 2015 to 2023, clinical secretary, POGS 2018-2019, treasurer, MSR Maharashtra chapter, ISAR 2014-2016, Indian Achievers Award for Chikitsak Ratna by Global Society for Health and Education Growth, New Delhi, Young Scientist Award at the 5th World Congress on Endometriosis, Japan, Lactacon Breastcon Conference convener, POGS for 7 years, first in Gulf region. In IBCLC exam 2006, she has done the done the Shirodkar oration in Solapur OBGY Society 2016. She has been my teacher. A warm welcome to you, ma'am.
Thank you, Saman, for the kind words and nice to hear from the student. Thank you so much.
Welcome, ma'am.
Thank you,
Next, I
ma'am,
would
for
like-
accepting the invitation and being there.
Next, we have Dr. Vandana Gandhi, ma'am, all the way from Canada. She is MD, DGO, obstetrician and gynecologist. She has a diploma in pelvic endoscopy from Germany. She's consultant in OBGY, sonologist and endoscopic surgeon. She is founder, Female Fetus Protection and Save Girls Counseling Center in Akluj. She is founder of Akluj OBGY Society 2013, president of Akluj OBGY Society 2018-19, member of Contraception and Family Planning Committee amongst 2018-2020. Madam is very active with her poems and she keeps winning a lot of prizes for her presentations. Welcome, ma'am.
Thank you. Thank you, Saman.
I would like to add one more to her introduction. She has also designed an anemia model for school girls, which we are now advocating with the FOXY and the Public Awareness Committee, and it has been accepted all over India and it has received quite a lot of accreditation from UNICEF too, ma'am.
Thank you, Monica. Thank you for the mention.
Next slide, please, Sachin. Previous one, please. I would like to welcome Dr. Suvarna Samir Bhopre, ma'am. She is MBBS, DGO, FMAS from MUHS, FIC, MCH, FCCS. She's a cosmetic gynecologist. She is managing director of Sri Sai Hospital Maternity, Surgical, Childcare and Laparoscopy Center in Akola, PSC Committee in charge Akola OBGY Society. Ma'am has special interest in high-risk pregnancy, laparoscopic surgery, and cosmetic gynecology. She has published more than 10 articles in national and international journals, received one as best paper as well. Actively participates in FOXY medical education program. Welcome, ma'am. I would like to welcome Dr. Aarti Kulwal, ma'am. She is MD, OBGY, DNB, PG, DHM, Medical Superintendent, District Women's Hospital, Akola. She has presented various papers and also won the Best Paper Award in AMOX 2011 and 2013. She has also won Best Paper Award in Critical Care Obstetric Conference 2014. And she has special interest in RMNCH activity. She is the activities trainer for BEMOC, EMOC, PPIOCD, SBA training, and also a DNB guide. A warm welcome to you, ma'am.
Thank you.
Next slide, please, Sachin.
Ma'am,
Dr. Kundan slide.
please. You are doing the previous one. Sachin, you have to come down.
Ma'am, I have all these slides only.
No, the last one I had Dr. Kundan sir's
Okay,
slide.
ma'am,
Yeah,
Yes,
Mangal
yes,
madam.
yes, ma'am. He's reading there, ma'am.
The one previously also. You have to introduce Dr. Mangal
Mangal
madam.
ma'am's slide.
The previous slide, please. Yeah.
I would like to introduce Dr. Mangal Sharad Rathi ma'am. She's passed MBBS DGO in 1994 from SRTR Medical College, Ambasogai, practicing in Paratwada, District Amravati since 1995. She is interested in obstetric sonography. She has received the late Shailaja Chaudhary Award from Amravati OBGY Society in 2021, Wonder Amoxian Award in 2023, Wonder Foxian Award in 2019. She was panelist, chairperson, and speaker in Amravati CMEs. She has received many gold medals and silver medals in IMA swimming, state and national level. She covered more than 40 schools for anemia, menstrual hygiene, self-defense in young girls, and also covered more than 5,000 ladies under cancer awareness work in Melghat area and gave information on ANC care, high-risk symptoms in multiple PHCs. She has published a book giving information on women diseases, Stri Arogyam Dhan Sampada in Marathi language, and distributed 1,000 copies in Melghat areas. Wonderful work, ma'am. Extending a warm welcome to you.
Thank you very much for nice introduction. Thank you, madam.
Last but not the least, I would like to introduce Dr. Kundan Chopde, sir. He is MBBS DNB Pediatrics, MBBS from Grand Medical College, Mumbai, DNB Pediatrics from Dr. Kasliwal Medical Care and Research Foundation, consultant pediatrician and neonatologist at Chopde Childcare and Chirayu Children's Hospital, Solapur, assistant professor at Ashwini Medical College, Solapur, past organizing secretary of Mahapedicon 2015, Solapur, and conducted Mahaneocon 2023 in his presidency. He is current Solapur Pediatric Society president. Welcome, sir.
Thank you, ma'am. I want to say one thing, that this type of interaction between obstetrician is very much needed on same platform, because when the neonate is admitted in NICU or when patient is with us, even that time also he has more faith on our gynecologist and obstetrician. Whatever we tell them, they again cross-check with their obstetrician and they believe in obstetrician. So we should be on same platform so that counseling of the patient will be better.
That is why, sir, we've invited you today. He is also the president of IIT Solapur. I welcome all the esteemed faculty, and let's now start with the symposium. Sachin, you can stop sharing all the slides so that this is just a formal question answer session.
Yes, ma'am. Already I have stopped sharing.
Thank you. Our first question for today's symposium goes to Dr. Vandana Gandhi, madam. What is the antenatal counseling that is required for the preparation of future mother, and how important is it to examine the breast in the antenatal period?
Thanks, Monica, for inviting and thanks for this opportunity. As there are two questions, what is the antenatal counseling required? As an obstetrician, I think that we should be always with personal touch with the patient to give them tender care. And during counseling, every antenatal visit is an opportunity to talk with her and to remove her fear in any respect, which helps to reduce her anxiety and stress. Future mother needs a balanced and well-planned diet, some antenatal exercises to keep her fit, her regularity in meals, and on our part, we should give them supplements of iron, folate, and calcium vitamin D3 so that it helps her baby's growth and weight, and timely vaccination of TDVAC and Tdap, which gives protection to both from tetanus, pertussis, and diphtheria. We need to counsel her about feeding, especially for primies who has more anxiety and fear. I routinely use some video counseling which are self-explanatory. There are some good videos from nucleusinc.com and some softwares. After 28 weeks, we need to check for both breast and nipples for any abnormality, like retracted nipple or inverted nipple, which may be also a fear in her mind about breastfeeding. If any tumor or any abnormality in the breast itself, I usually advise them to use coconut oil to apply to nipples after daily bath, which helps to make nipples soft. Once a week, she can gently pull and rub to remove the sticky debris and keep the nipples clean. Also, we need to reassure her about breastfeeding, which is a physiological and natural process. She should not bear any anxiety whether she will get enough milk or not. We need to encourage her breastfeeding, and explain her the benefits, the tremendous benefits of breastfeeding. Today, we are discussing all about that to both mother and the newborn. Finally, we have to ensure about her safe motherhood, for which we all obstetricians are standing by her side. She needs periodic antenatal visits scheduled by her gynec and for early diagnosis and treatment of any deviations from normal pregnancy. Apart from that, if we are very busy, we should manage a separate counselor for her fear, anxiety, and to encourage her to cope up with the labor and breastfeeding.
Thank you, ma'am. Mia, ma'am, do you want to add anything?
I think before me, I would suggest that Dr. Mangala should add something about the care of the nipple, what Dr. Vandana is also talking. So once she finishes, then I will give my remark.
Yes, thank you,
Yes,
Sneha.
yes, ma'am.
Thank you first, Amox and Monica, for inviting me and to be part of this beautiful webinar. Very nicely, Vandana has elaborated. Thank you, Vandana.
Hi,
About
ma'am.
just this antenatal preparation, we have to be little caution, because there is a lot of now research recently has done. Because if we focus on mother's nipple, then she may feel that there is some problem with her and her confidence may go down. And actually, during that later part of the pregnancy and delivery and postpartum, there are physiological changes in that nipple and areola, and it is very stretchable. So ideally, we can examine the breast and see if the nipples are flat. We can just note fine, but we actually try to avoid telling her that pulling of the nipples or telling her that her nipples are flat. And I think antenatal classes, the main purpose would be just to prepare her for the breastfeeding. And if there is a problem, she should know where. This is very, very important. And also she should prepare when she goes to the work about the leave and everything that we will discuss later on. But if we discuss all those during pregnancy, she has time to make the arrangements for different things. Thank you.
Yeah. So just last few words from me, Monica. So as we are talking about the preparation of the mother for breastfeeding, it should be physical as well as emotional. So physically, the mother has to be in good health. We have to see that she doesn't have any comorbidities which are pre-existing, and she doesn't land up into pregnancy complications. If at all she lands up into, we have to tackle at the earliest. We have to give her good diet and adequate exercise, whatever way we want to tell her. Then comes the emotional aspect, where we have to actually prepare her that, how important breastfeeding is, and how breastfeeding gives her pleasure, and how it is helpful to the baby as well as mother. As Madam Mandakini has also said, not only to the baby mother, to the family, the country, and the earth as well. So we have to prepare her emotionally as well, that how it is beneficial to everybody. On the other hand, I would say that everybody is talking about the benefits of breastfeeding to the baby and to the mother, but we should talk to her that if the baby is not breastfed, then what happens? The sudden infant mortal death syndrome happens. So many complications of this allergic diseases, asthma, even the GI illnesses, the upper respiratory illnesses. All these are almost multiple folds. So we have to just tell her that she should be happily ready to breastfeed a baby, and she should be, healthy. I think that's all from my side. Thank you, Monica.
Thank you, Vandana ma'am. Your points were very well taken. Vani ma'am, thank you for the additions. Dr. Mangal Ratki, what is the dietary counseling in antenatal period and the postnatal period? And are there any myths that you want to clear regarding this?
Thank you, Monica Madam, for making me part of this wonderful webinar. Dietary counseling in antenatal and postnatal period. Dietary counseling about healthy habit is recommended for pregnant women to stay healthy during pregnancy and postnatally. A healthy diet during pregnancy contains adequate energy, protein, vitamins, minerals, and it should be obtained through the consumption of variety of locally available nutritious foods like green and orange vegetables, meat, fish, beans, nuts, pasteurized dairy products, fruit, and fortified foods. Counseling should be woman-centered and delivered in a non-judgmental manner. In undernourished population, nutrition education on increasing daily energy and protein intake is recommended to reduce the risk of low birth weight newborns, and balanced energy and protein dietary supplementation is recommended to reduce the risk of stillbirth and small for gestational age newborns. Daily oral iron and folic acid supplementation with 30 to 60 milligram of elemental iron and 40 microgram of folic acid is recommended to prevent maternal anemia, purpura sepsis, low birth weight, and preterm birth. Intermittent oral iron and folic supplementation with 120 milligram of elemental iron and 2800 microgram of folic acid once weekly is recommended. Again, antenatal multiple micronutrient supplements that include iodine and zinc in the form of 220 milligram of iodine per day in pregnancy and 290 milligram per day in lactation. Again, zinc 12 milligram per day in pregnancy and lactation is recommended. Daily calcium supplementation 1.5 to 2.0 gram oral elemental iron is recommended. Vitamin E supplementation is also recommended to prevent night blindness. Again, if vitamin D deficiency is there, then supplement 1000 to 2000 international units per day can be considered. Again, we should encourage them to take low caffeine intake diet. And postnatally, all women should be consulted on nutrition as part of postnatal care. Postnatal diet follows the same diet mantra as pregnancy. The first 6 months of lactation and for the next 6 months after lactation, addition 400 kilocalories energy is required. Protein requirement is at its highest during lactation, at its reaches to its maximum requirement. Therefore, the nursing mother needs about 20 to 30 gram of protein over and above her normal requirement. And the most part is exclusive breastfeeding is recommended for the first 6 months. That is the most important dietary concept. Now, there are few myths I want to discuss. There is most common myth is we should not eat papaya, mangoes, pineapple because they may cause miscarriage. That is totally wrong. Normal consumption of ripe papaya during pregnancy doesn't pose any risk. Ripe papaya has a very good source of vitamin A. Unripe papaya, on the other hand, contains chymopepin, and pineapple has an enzyme called bromelain, which when consumed in large quantities can cause uterine contractions. Again, second myth is that spicy foods eaten during pregnancy can burn baby's eyes, resulting in blindness. This is also wrong. Spicy foods can increase the pregnant woman's risk of heartburn, so we should decrease their intake. Third myth, very common myth, that pregnant women should not consume haldi. But it is the most antioxidant rich yellow, so there is no any difficulty during consumption and don't have any side effect. Myth number 4, drinking chai leads to darkening of baby skin. This is also wrong. 1 or 2 servings of caffeine a day has not shown any side effects. Again, nuts are not good for pregnancy. It's a very common question in our Melghat area. And they says that it provides heat. But this is also not true. Eating nuts during pregnancy may lead to improved cognitive ability in children. Nuts are rich source of vitamins, minerals, and can be used as healthy snack during pregnancy. Kesar. There is again, kesar in milk has 2 myths, that it is garam and some says baby gets fair, but both are not true. Saffron is rich in antioxidant It decreases mood swings and cramps during pregnancy. Myth: pregnant women cannot eat fish, meat, eggs, meat during pregnancy as they can harm the fetus. It is again a big query. But actually, meat, poultry, fish, and eggs contain protein, vitamin B, and iron needed in pregnancy. The developing fetus needs plenty of protein. Fish contains a lot of omega-3 fatty acids, which can be very nutritious. And the last, coconut. Coconut, it's baby become very hard, baby head become very hard like coconut. This is also wrong. Okay, thank you very much.
Thank you, ma'am. Mangla ma'am, Vani ma'am, do you want to add something to this? Then we'll go to Dr. Sneha ma'am also.
I think there is a nicely elaborated and lot of points and the myths are covered.
Thank you.
Basically, the breastfeeding mother, she should be happy. So whatever she is eating, she should like the food. That is very, very important. And also the pregnant woman. Because if we say ki you should eat this much grams of that or you eat protein, she may not understand. So generally, average, we have to tell her what is right and what is not wrong. But I think it is very nicely elaborated.
Sneha ma'am, for your comments, please.
I think she has explained it so beautifully, very elaborate discussion, I would say. Only the myth we have to remove that, once the baby is delivered, now her requirement will be less. That is what the only message we want to give, that whatever caloric, not only caloric requirement, but even the calcium and whatever vitamins she has already discussed, I don't want to repeat it. In fact, the requirement is more. That's what we are supposed to, supplement it in a adequate quantity. That's all I think. Thank you.
Right.
That was very extensive.
I just wanted to add one thing is in Maharashtra, typically everybody gives only clear liquid foods. All the vegetables are made in the form of a curry and then given to the mother, saying that if the mother has hard and solids, then the baby is going to have loose motions. So most of them don't have the vegetables here.
Yes.
Has anybody experienced that along with it? They don't give vegetables here, ma'am. They give only watery substances. The dal is also very watery. So is there any correlation that you can advise the actually patient's relative that this is not the diet that is required to be followed, or what exactly needs to be given to them? Because what I generally advise is what you have, you give the same to the patient. Don't make anything else for the patient.
Shall I add something? Shall I say something?
Yes, ma'am, definitely.
Actually, what is the societal or rather we should say Indian system? As soon as the mother gets delivered, we make her sick. Actually, she is not sick. She is a patient who has just delivered the child by vaginal route or by abdominal route. But our system is so much taboos and these customs and all those things make her patient. Actually, she is not a patient. So whatever she was eating, if there is cesarean delivery, then as per the doctor's advice, she should eat all the food what she used to eat previous day of the delivery. But we restrict water, we restrict salt, we restrict sugar, except gestational diabetes is there or the specific situations are there, nothing to be restricted. Otherwise, what happens? She feels that I'm patient, I should not eat this, I should not eat that. So there occurs a control over diet. So all these things make her anemic. If she is not anemic, she can become anemic. If she is already anemic, the anemia can worsen also. So one thing we should tell, whatever diet she is taking, and all the other members of the family is taking, the same diet should be given to the mother, except if she's a like slim lady or no calorie, extra calorie, because she will need extra calories, extra protein. So something enrichment can be added. Nothing should be deducted from a regular diet. Nothing should be deducted. We can enrich by adding ghee. If she's not too obese or obese, we can enrich by adding green vegetables. On the contrary, the people don't give salt, don't give water, don't give vegetables. All these are taboos and wrong traditions which we are following. Pani jaisa, dal bhi kaise pani jaisi. so that the baby should digest. And the same thing is done with the baby also when they start complementary feeding. All these are wrong customs. Whatever diet, standard diet, the home is going to prepare for all the members, except one thing. I always advise the chili powder. Chili powder or the mirchi, just for the taste. अपने जबान के लिए जो मराठी में चोचले म्हणतात ना त्या करता है. Otherwise, chili powder is not essential for anybody, but just to add taste, with slight chili powder in our diet. Except the mother is hypertensive or the mother is having diabetes, no restriction should be there on diet.
I think we can't hear you, Monica.
Voice is breaking, Monica.
Ma'am, am I audible now?
Yes.
Okay.
Yes,
ma'am.
now.
Yes, ma'am. The next question is for Vani ma'am, that how we will counsel the new mother regarding the positions and latching of the baby, and what is the most comfortable clothing that we advise for the mother?
Yeah, very important question, and a very important thing that all the health professionals, particularly all we obstetricians, we need to know. Now, because if the latching and the position is not proper, the baby is not going to get milk. There is not going to be effective milk transfer from mother to baby. And when the baby is not latched, the mother is also going to end up problem, starting with the nipple trauma, then engorgement, mastitis, abscess, all those things are going to start. And then her milk is going to become less and less at the end of the day. So the latching, and that has to be, from the beginning. Now we say initiation of the breastfeeding within 1 hour after birth. So as soon as the baby is born, there has to be skin to skin contact between mother and baby. And then within 1 hour, when we say initiation, we have to support this mother during that time. And even whether it is normal delivery or whether it is cesarean section. Now latching is, baby doesn't latch only to the nipple. So maximum even the areola should be also in the baby's mouth, because it is so stretchable. And when the areola is also in the baby's mouth, the nipple goes near the palate of the baby, near the soft palate. And so there is no nipple trauma, and the breastfeeding is not supposed to be painful. So 4 points, this is the baby. Say hello to everybody. So 4 points for the baby, how the baby latches, that baby should do the maximum R. So that the maximum, that not only nipple, the black part, particularly the lower black part goes into baby's mouth, because baby takes the tongue out and then latches. And then the third is, baby's head should be little extended. Like when we are drinking the water, we don't drink like this. Our neck is little bit extended. So like that, we don't press on the baby's head. Then it becomes flexed, and then the baby tends to come out. So always support the neck. And when the baby's head is extended, then the chin touching the breast, the chin hugging the breast, and automatically the lower lips becomes everted out. So very important points. And then another thing is, baby should be completely turned towards the mother, because if the baby is mother holding like this and the neck becomes like this, then again like we drinking water like that. So it should be in the same axis, and then we should support the baby's body and the baby's bottom as well. That is also important. So skin to skin contact, the mother's tummy and the baby's tummy touching each other. And that is why when it comes to the clothing, the mother should wear open clothes. The front should be open. So no chain wala gowns or chain wala bras, because then it is not like bottle feeding that only the nipple is out. So skin to skin contact is also very, very important during breastfeeding. And then the mother should be also comfortably sitting, because if she sits at the edge of the table and the bending like that, she will get the shoulder ache or back ache, and she will not able to feed for longer time. So we have to make sure that she's sitting comfortably with her support to the back, and even her feet should be supported. Suppose if she's sitting on the chair, not just hanging like that. And then when the baby comes, does the ask, then the baby should come to the breast, not mother going to the breast. And then she should hold the breast. Normally what happens, the mothers tend to hold like that, Caesar hold. So when we say the maximum black part, with the Caesar hold, it is not possible. So how mother should be holding the breast? C-shaped, means 4 fingers down and the thumb up, like this. And she should push the breast in the baby's mouth. Not even sometimes they even the press here, because they are worried about the baby's nose, that it will become flat or baby will not able to breathe. But even if we touch the nose, we still, you see that you are able to breathe. So we don't have to worry about the baby's nose. If the baby's head is extended, the chin is touching, and automatically the nose is away from the breast. And then when we push the breast like this, then the baby latches beautifully, and then the baby starts sucking. So these are the few important things. Again, how the mother holds the baby, the typical, the cradle hold. That means suppose the mother is breastfeeding the left side, then with the left hand, she can just hold the baby like that. Not like this, but just supporting. And cross cradle, cross cradle position. When cradle is the Palna Paddhat, and this is a cross cradle, Sudharit Palna Paddhat. So because the baby's neck, as we said earlier, weakest, she holds nicely the neck, and then she supports the rest of the baby's part as well. And with the other hand, she supports the breast, and when the baby does quickly to the breast. Now, newborn baby, this cross cradle works very well, because then the latching doesn't become loose. Once the baby and the mother, they both are learned the skills, then the cradle hold is okay. Another thing is the football. So it is like a cross cradle, but when mother is holding the baby with the right hand, she feeds from the right breast, and the baby is under the arm. So like a football holders, they hold the football. So this is for the twins. The mother can breastfeed on the both sides at the same time. Or mother, if she has a pendulous large breast, so even this, then football works better, in those conditions. Or sometimes baby refuses in the cradle hold, cross cradle. So आपल्याला जरासं बाळाला फसवावं लागतं, आणि जरासं वेगळं पोझिशन दिलं की many times the baby starts latching. And fourth is the lying down. And the important myth, even in the hospital, they say ki, you should not lie down and feed the baby. But if you see, when the mother is sitting, the baby is like this. And even when the mother is lying down, still the baby has the same position. So baby's position doesn't change. And plus, what will happen? The mother will get the rest. So she cannot sleep and breastfeed. We said she's lying down, but she's awake. So she's turned on one side, baby's turned on other side, and the mother can breastfeed in the lying down position as well. In the Western country, there is another laid back position. So mother is 45 degrees, and by gravity, then the baby latches beautifully to the mother. So that is also very good position actually to adopt. So anyone wants to add into that?
Ma'am, I want to say something.
Yes, Saman.
Yes, Saman.
Ma'am, my daughter was born preterm at 35 weeks. Once she finished, she reached the near term period. After like 6 weeks were over, I started feeding her in the lying down position, and that is when I actually noted her good weight gain.
Very good.
Initially, I was also very concerned that I am lying down and feeding, but she is most comfortable when I'm lying down. So if we are alert, it was actually helping milk transfer when I was lying down and when she was feeding.
That is what we wanted to highlight, Saman, that you should be lying down but not asleep.
Not asleep, yes.
That makes the point, because being asleep gives you the maximum cord deaths in the municipal hospitals.
No, but I have never seen, the cot death because mother sleeping and then she's on over the top of the baby, because the maternal instinct is so strong. When the baby is next to her, I don't think it is going to happen. It doesn't happen.
I just make one comment here. Mangala is, of course, she is a lactation consultant, and her word is final because, she has ample of knowledge and information, and she has the lots of experience as well. So I was very keen for her to become the breast committee chairperson. What we have been in fact taking advice from her also. So Monica, what I feel that previously we used to say that, the mother should not feed in a lying down position because of whatever fear, but there is absolutely no contraindication nowadays. Sideline position is supposed to be one of the best positions to feed the baby. And I think we have to remove the myths. Whatever cord death and this cradle death has happened, that is because of aspiration. And I think that we have to warn the lady that once you feed, you hold the baby upright and maybe little patting or all these things. And she should not put the baby immediately down, which the baby vomits inside and then aspirates. I think that's all. Otherwise, Mangala has done wonders to her job.
Yeah, thank you, Sneha. Keep blessing me.
Shall I add one statement?
Yes, ma'am.
Yeah. Actually, what Mangala Vani madam has told correctly. In Marathi, there is one saying like Sukhasan. So you and me cannot dictate mother which breastfeeding position is correct for the diet. It depends upon the mother and the baby. In what position both are happy,
comfortable, whatever is comfortable.
That is called as Sukhasan. And second thing, what Sneha was just referring to, sudden infant death syndrome, SIDS. It's not because of breastfeeding in lying down position. It is because of many intrauterine causes that can give rise to sudden infant death syndrome. But in our society, it has been blamed to breastfeeding because the mother breastfed in lying down position. That's why the seeds occur. It's not like that. It is because of many intrauterine causes that gave rise to death of the baby, but not because the mother was breastfeeding in lying down position.
In fact, it is the other way around. We are claiming that, breastfeeding protects the baby from sudden infant death.
Correct.
So that's why
Pediatrician is here. They can make some
we
comments.
must remove this because she was breastfeeding in lying down. The baby died. So many people used to believe like that. So we must correct this notion. Yeah. Thank you very much.
I think pediatrician we have Dr. Kundan. So
Yeah.
he will be the best person.
Ma'am, most of the cause of sudden infant death syndrome is aspiration, as you are told correctly. When mother is feeding and she is awake, there is less chances of aspiration. So you have to do burping. That is very most important thing. What happened most of the time after one burp, they take baby down. You have to keep after burping also, you have to keep 10-15 minutes upright position for the baby. And it is not really
I will like to
position of the feet.
Dr. Chopre
Yes.
Kundan sir has said, just not told. When I asked to one pediatrician, senior pediatrician, so what we used to do during our times, we used to hold the baby like this and birth like this. So they said, no need to do like this. No, we can keep the baby upright or in any right lateral position. That is also equivalent to burping. So even if the mother breastfeed the baby in lying down position, she can make the baby on one side or upright so as to avoid aspiration. But breastfeeding as such is not responsible for the death of the baby. That I wanted to clear.
Yes.
Yes. Thank you everyone for your inputs. We go on to the next question. The next question is for Dr. Saman Tamori. How important is colostrum and how early should we start breastfeeding?
Thank you, ma'am. The first milk that comes as soon as the mother has delivered the baby is known as colostrum. It is actually liquid gold. I cannot emphasize on enough on its importance, because earlier it was a practice to discard the colostrum, but it is liquid gold. It's called liquid gold because of the beta carotenes that are present in it, which are the antioxidants which impart a goldenish hue or orangish hue to the colostrum. So it is the first vaccine that you give to the baby, I can say. It is rich in immunoglobulins, which is an antibody, lactoferrin, which again prevents against infection. It has a lot of leukocytes, WBCs, which help in fighting infection. It has epidermal growth factor, which will stimulate cell growth. And it is also, the baby's gut is sterile. So when colostrum is the first thing that is entering the baby's mouth, it will line the gut and prevent the baby from infections, and hence, prevents the baby from diarrhea also. It also aids in passing of meconium. It is also the first learning experience for the baby to breastfeed, because it is thick, it is small in quantity, and as the baby tries to latch, it learns how to suck, swallow, and breathe. So colostrum is very, very important, and that should be the first thing that enters the baby's mouth as soon as it is delivered. What happens is, most of the times we tend to separate the mother and the baby after birth. The baby is delivered in the labor room, and then the pediatrician is waiting outside, and it's quickly cleaned, the cord is clamped and cut, and we separate the baby. And the stimulation and whatever suctioning is to be done, that happens somewhere far away from the mother. But that should not be done. Firstly, we should inform the mother in the antenatal period, as all the seniors have said, about the importance of colostrum. And immediately after the baby is born, we can just clean the baby and give skin to skin, initiate a breast crawl, and colostrum should be the first if the baby does not require resuscitation, after the opinion of the pediatrician, I'm saying. And then that should be the first thing. You should encourage the baby to latch, and the baby should be kept skin to skin on the mother, and baby should be given the colostrum after a normal delivery. After C-section, what I'm doing with my patients is that I'm expressing the colostrum out, and if the baby cannot be latched on to the mother's breast, I'm collecting it in a syringe and then handing it over to the pediatrician whenever the baby is ready. That can be fed to the baby. So the golden hour, the first hour of the after birth is the most important period, and colostrum should be administered as soon as possible to the baby.
Sneha ma'am, for your final comments, please.
I'm sorry, I think I missed the discussion. I
Yes,
think
ma'am.
so she was discussing well. I think we can go ahead.
I think, well, I will add only one advantage that is very important. I think she said something about carotene, no? Yellow color of the colostrum. So this vitamin A rich colostrum, it lines the inner coating of the intestines. And because of that, it prevents allergic reactions. So the baby becomes less allergic to any allergen. And in future also, this coating of the intestine, because of the carotene, because of the vitamin A, in high quantity in colostrum, that prevents the baby from allergic disorders in the future. So that is very important advantage, because we know the surrounding atmosphere, how it is disturbed. So less chances of allergy if the baby is colostrum fed.
Ma'am, can we move ahead to the next question? Yeah. Dr. Suvarna ma'am, how will we handle the low milk supply, and what will you recommend top feeding? Suvarna ma'am, is she there?
We do have three people joining as faculty, but then unless they open their
anybody can take up the question if madam is not there.
What is the question, Monica?
How will you handle low milk supply, and will you recommend top feeding?
In early stages, we should not recommend top feeding. I think we should find out what is the problem of low milk supply, whether latch is not proper, whether mother is not feeding frequently. Frequent breastfeeding and breast massage encourages the milk supply, or there is any nipple problem. All these problems should be find out first, and if encouraged and breast massage is given, she will have. Even psychological stress or anxiety or any other tensions for the mother may hamper the breast milk supply. So these can be removed first, and if at the last resort we can take the help of top feed.
Yes, I think Vandana has made it very short and crisp and very clear. But I would just say that yes, we're talking about the oxytocin reflex. So the mother has to be happy, fearless, and relaxed, and she should be free of pain. On the other hand, if all these things are present, it will hinder the oxytocin reflex. So we have to make sure that she's physically and mentally healthy, that we have to see, and she's not suffering from any of these. So if at all she has anxiety, we have to counsel her, relax her. If she has some sort of pain, then we have to give her analgesics. So all these things we have to take care first. Then of course, plenty of fluids, especially water, and not the caffeinated drink, and the healthy diet, and encourage for breastfeeding. As she has rightly said, frequent, complete, and unrestricted feeding with the proper latch. I think that's a very clear-cut message what Dr. Vandana has given, and that should go a long way. I think all of us should make sure that the baby latches well. Correction of the latch per se will improve the baby sucking. On one hand, you have the maternal problems. On the other hand, you have the baby. The baby may be sick sometimes. The sucking reflex may not be good, so we have to work on that and advise her accordingly. So I think both the sides we have to take care as far as the low milk supply is concerned. As we talk about, nature is so great that it sends the whatever required amount, the quantity as well as quality of milk for the baby. And even I'm sure the lactation consultant always talk about, even if the baby doesn't feed for few hours for the first day, the baby has got the glycogen storage. So we need not worry about the babies, hungry and starving. So we should not worry. And not to go for any additional top feeds or whatever other means than the so we should not go for any infant milk substitute for that matter, may it be initial or even in the later phase. We stick to our principles of early initiation, which is very, very important. As all of us are recommending, as a chairperson also, I was talking all 4 years, I was talking, it should be how early that, you have to deliver the baby on mother's abdomen, let the baby crawl and go and have, start the breastfeeding on its own, what we label it as breast crawl. So whether it is a normal delivery or a cesarean delivery, we have to make the baby feed or initiate feeding at the earliest. Don't wait for the golden hour or so. At the earliest, I would say. So early initiation, frequent and unrestricted feeding, and the effective latching. Of course, the mother and baby's health should be taken care of. Thank you, Monica.
Madam, I want to add one point. When we explain the latching, usually primates have a superficial latch. We have to explain by a proper figure or pictorial one that the areola contains the breast pumps and the nipple contains only the lactiferous ducts. So if the areola is properly in baby's mouth and that is compressed, then only the ejection reflex is properly done and the milk supply is continuous. Usually, if the areola is not in baby's mouth, there is a superficial latch, and it will create, even if the milk supply is there, it will make the mother's confidence very low. She feels baby is irritable, baby is asking for the milk, and the latch is superficial. So even if milk is there, it is not properly let down. So the latch should be explained, and that is a very wonderful video which I show. That is a superficial latch and an adequate latch. So the areola, if compressed, it gives a continuous milk supply and not only the nipple. That we have to explain to the mother. I usually stand beside the mother to teach her the proper latch. That is most important, what I think.
Yeah, can I add something?
Yeah, I think Mangala has shown it with the model, whatever she has, no, the baby and the breast. She has very nicely shown the, the Caesar and the C, the V and the C. That is how the mother should hold. So over to you, Mangala, if you want.
Yeah, there is something called perceived low milk supply. Means that there is enough milk supply, but the mother thinks her milk is less. Why she thinks that way? Because the baby keeps asking again and again. Sometimes even after a half an hour, after 1 hour. And then she thinks because her milk is less. Actually, breastfeeding has no rules and regulations. Sometimes they have a growth spurt as well. So maybe asking after half an hour, after 1 hour, again and again. So that is one thing. Second thing is the breast they become soft after a few weeks. Initially, they are hard and filled with the milk. But later on, as lactation establishes, the breast becomes soft and they don't leak like one side she's feeding and there is a leaking other side. It doesn't happen much later on. So that also she takes it wrongly that now her milk is less. So we have to explain to her, we have to increase her confidence. So how she will know that her milk is enough for baby? And three important parameters. One is urine output, the second is the stool, and third is the weight. Now, after the lactogenesis 2, when there is a copious milk supply, the baby passes urine more than 6 to 7 times in 24 hours. And the stool, baby may pass ample 3 to 4 times, even some babies they pass after each feed. And that goes for first few weeks, maybe for 4 weeks. And after that, the stool pattern changes. And the baby sometimes may not pass the stool for 3 to 4 days. But that is normal after 1 month. But in the beginning, if the baby has not passed the stool for 24 hours or 2 days, it is not a good sign. That means the baby's intake is less. And the most important parameter is baby's weight gain. Initially, the baby loses 7 to 8% in first 1 week. And then the baby starts gaining weight. So by the time the baby is 10 to 14 days old, the baby's birth weight is back. And then later on, and the pediatrician, Dr. Kundan sir, please correct me because you are a pediatrician. So roughly 25 to 30 grams per day or minimum 600 grams per month, the baby's weight gain should be there. So if we, and that is why the follow-up and make baby's weight, at discharge, then at 1 week, at 2 weeks, so that even if you think the weight gain is not as appropriate, we should correct the latching. We should see the diet actually breastfeeding. And rather than just giving the formula, okay, if you think your milk is less, maybe you give one top feed. So that should not be case. There are measures to increase the milk supply. Suppose her milk is less, maybe baby is not gaining weight. So if we advise the top feed, we should not give the top feed as a separate. Always breastfeed first, and on that maybe then baby may need 20 ml or something, but never give only top milk and not skipping the breastfeeding. That is important. Thank you.
Yeah, I just wanted to add one thing when Dr. Vandana was talking that, when if the latch is not proper, the pumping, the lactiferous ducts which are draining into the nipple, they will not give you adequate milk let down. So the baby, keeps on sucking without effective milk pumping. So that is what the result is of ineffective latch, and very nicely Mangala has talked about it. So the baby remains hungry, so it asks for again and again in spite of the milk being there. On the other hand, the breast is not getting emptied, it gets engorged, so there is flattening or compression of the cells, and that is why the milk production or secretion, it may be reduced. So that is why we have to, in such situation, we have to actually give the warm compresses and gentle massage, and then you go for the feeding the baby or maybe extraction of the milk, and then the cold compresses, so that the situation is handled and the breast milk let down continues. And then you have to, of course, stress on the effective latching. That's all I think.
Madam, आपल्याकडे just a second. Can I add one thing?
Supply of the milk, what we have discussed just now. Regarding the supply, one important thing we should take into account, prolactin is the hormone required for milk production. So prolactin is there, more milk will be produced. So very important characteristic of diurnal, we can say, variation. During night time, if the baby is breastfed very well, prolactin is secreted more in amount during night time. So encourage the mother to breastfeed, because what happens, they breastfeed very well during daytime. And night time, the mother says, no, you take rest. I have something for the baby, you better take the rest. On the other hand, we should encourage night breastfeeding, so that more prolactin is secreted. Because of more prolactin, more amount of milk will be produced, and that will, whatever madam was saying, real or pursued less milk supply, all these things will be removed just by encouraging night breastfeeding, and roughly 8 to 10 or 10 to 12 hours over 24 hours, but no wall clock is required for observing every 2 or every 3 hours like that. It's a wall clock that is inside the baby's stomach. That is the imaginary wall clock that is inside the baby's stomach. Demand feeding after 15 days, not in the first few days. It will like take the baby frequently, so frequent skin contact and frequent stimulation, frequent emptying of the breast, that gives rise to more milk production. But one important thing of prolactin hormone, if we encourage night breastfeeding, more prolactin, more production of milk supply. That is very important thing we should teach our mothers.
Vandana ma'am, you wanted to add something?
Yeah, I just wanted, I will better explain in Marathi in this point. आपल्याकडे जी ट्रॅडिशन आहे की घरचे लोक शिकवतात हाऊ टू होल्ड अ ब्रेस्ट. दे युजली ऍड की कात्रीत धरायचं, आणि ती कात्री धरण्याची जी 2 बोटांची जी स्टाईल आहे त्याच्याने ते निपलच ते एरिओला धरतात. एरिओला शुड बी इन बेबीज माउथ. तर कात्री धरण्याची ऐवजी खालून ब्रेस्ट सपोर्ट केला पाहिजे, सो दॅट फुल एरिओला बेबी कॅन टेक इनसाइड. That habit we should discourage and tell them how to hold the breath so that the latch is perfect.
It should be capital C, thumb above, 4 fingers below.
त्या घरच्या आपल्या ज्या सिनियर लेडीज असतात आपल्या पेशंटच्या, ते कात्रीत धर म्हणतात, मग ते एरिओला मदर धरते, फक्त निपल राहतं. दॅट शुड बी डिस्करेज और दॅट शुड बी टॉट प्रॉपरली हाऊ टू होल्ड.
मी तेच म्हणतो की तुम्ही जेव्हा कात्रीने धरता ते दुधाला पण कात्री लागते.
Sure, ma'am. Let's move forward for the next question. Dr. Aarti, what is the breast crawl? How do we practice rooming in, and how effective is it in clinical practice?
Thank you, madam, for making me part of this session. Actually, hello.
हो, येतं ऐकायला.
येतं ना? We are discussing about breast crawl, na?
Yes, ma'am.
Actually, crawl is defined as an organized, spontaneous behavior sequence of newborn to seek and move towards the nipple and initiate breastfeeding. Actually, this is a very basic natural instinct of any healthy baby that occurs when a newborn is placed on the mother's abdomen immediately after birth. And the factors promoting the crawl mechanism is that the smell of mother and the smell of amniotic fluid initiates the movement of baby towards the nipple. The breast glands also secrete odors that attract baby, and the dark areola and nipples helps in eye catching of the newborn. Also, the sound of the mother and the sound of the heartbeat of the mother makes baby to crawl upwards towards the breast. So this is a very basic instinct of any healthy baby to start her journey for the successful breastfeeding.
Yeah, I think the breast crawl, the baby can do breast crawl very well. That is indirect suggestion that baby's sensory and motor reflexes are there right from the birth. So it is indirect indication that both baby's sensory, smell, taste, ear, all touch of the mother, all the sensory, smell important because that smell of that typical taste of the milk rather gets attracted. And vision, because it is intrauterine, something cloudy like or some darkness is there. And the color of the areola is also dark brown. So all these 5 sensory, the organs are active at birth. So it is an indication that good sensory activity and motor, because the shoulder and the pelvic girdles, they move like this breast crawl. So again, the motor activity and sensory activity, both is there okay as per the demand, as per the requirement. So it's the indirect sign that baby is doing breast crawl, and for a certain time it is allowed. If till that time, if the breast crawl is not happening, then of course we have to support the baby and hold to the mother's breast. But we can give chance, and again self-reliance. Baby learns self-reliance right from the birth. मी स्वतः शिकलो आहे कुठली गोष्ट, जरा स्वावलंबन म्हणतात, ती एक गोष्ट बेबी शिकतो जन्मापासून. बेबी हॅज मूव्ड टुवर्ड्स द ब्रेस्ट ऑन इट्स ओन, नोबडी हॅज हेल्प. We have only just supported the baby so that the mother is tired, the baby should not fall. The breast call is very indirect indication of many good things that we should welcome breast call and teach our staff. If the staff is less, or Maushibai Daya can get trained for proper breast call.
Yeah, so we always
our August gathering, madam. I was when BPNI Maharashtra State President. That time, for the first time, this breast call video was released by BPNI Maharashtra on 1st August with the collaboration of WHO and UNICEF. Raji Nair was there, and Dr. Prashant Gangal, Dr. Sanjay Prabhu, and many more BPNI activists were there. And that time, this is my luck that I was president that time, BPNI Maharashtra State. I would like to.
Madam, you also guided our women hospital staff by Zoom meeting, and also many sessions were taken by you for the promotion of breast call in labor room itself. So we have started all the mothers who are delivering vaginally, the babies who are well at birth, they are made to crawl on the breast, crawl on the abdomen. So that mechanism is still going on, and I urge all the private doctors also to give the baby and to make our babies स्वावलंबन करावं आपल्या बेबींना. That is the take-home message from this question. And
Alka madam, that is a very wonderful video. I have seen it personally. That government video release is very wonderful.
Thank you.
Thank you, ma'am.
Yeah.
We now move forward to the next question to Dr. Kundan Chopre sir. That is, what advice will you give to the mother of the baby when the baby is in ICU or is an extreme preterm?
Yeah, ma'am. Thanks. First, when baby is in ICU, I will first tell mother that the baby's what is the neonate's condition is there, and I will re-emphasize. Am I audible?
Yes.
Yeah, I will re-emphasize the need of baby to keep in NICU. I will also assure that the baby is in expert hand and the baby needs special environment like warmer, IV fluid, oxygen. This is very important. As we have discussed, oxytocin reflex, the mother's worry, doubt, and other stress that can affect her milk production. And so that will hamper for milk production. And same breath, I will tell her that even when the baby becomes stable, I will start the baby feeding so that when I will start the feeding, I will require breast milk from you. So you better start expressing breast milk. That will be helpful for her in two ways. That will avoid her engorged breast, mastitis, and it will also help to establish prolactin reflex. As madam has told, prolactin reflex, dry urinal variation is there and it is more in the night time. So expression of breast milk should be done in the daytime and also in the night time also. As this will help when we start the breast milk to baby by orally or this nasogastric tube. At that time, milk production will be good. And next thing regarding preterm babies, this is very important. As I have mentioned, two reflexes, oxytocin and prolactin here. There are two more important reflexes are there: swallowing reflex and sucking reflex. Sucking reflex is there. Most of the time, obstetrician sees that sucking reflex is good. But what happens? The swallowing reflex comes at around 34 to 35 weeks. Till that time, we cannot start baby on breastfeeding. If baby is more than 34 weeks preterm, that is, we call it as a late preterm. So we can start breast milk to the baby. That can be given by breastfeeding or oral feeding can be started as the swallowing reflex is well maintained. And if baby is less than 34 weeks, we have to give this orogastric or nasogastric feeding should be given. When for preterm feeding, we as a pediatrician are more worried for two things, that is risk of aspiration and second is risk of NEC, that is necrotizing enterocolitis. So what we start, we do trophical feeding. So we give small quantities of milk and that is increased, very small amount is increased every day. And then we can advise mother so that she can do non-nutritive sucking. In that case, we empty the breast and give the baby for feeding, which are less than 34 weeks, where sucking is good, but swallowing is not there. We ask the mother to give baby non-nutritive sucking. That will help moromotor stimulation for the baby. And also that will give confidence to mother. And also there is kangaroo mother care can be given by the mother. And third thing for preterm is the fatigue. Most of the time baby sucks and then he fatigues early. In that case, we can give baby oral feeding, or if it is less than 34 weeks, we can give nasogastric or orogastric feeding. That is regarding preterm feeding, ma'am.
No, that's very.
Does anyone want to add? Yes, ma'am. Ma'am, you can continue.
Yeah, actually very nicely elaborated. Just about the sucking, I have seen babies even 30 weeker, 32 weeker also, they suckle very well.
Yeah.
And anyway, initially the colostrum is in very small amount. So if we continue to give that skin to skin and kangaroo and let the baby start suckling, we can try. Even I have a baby who is discharged home with 1.2 kg and breastfeeding.
The king is there, but what happens?
What my question is, we don't have to wait till 34 weeks for the baby to be at the breast. We can give a try, see if the baby is sucking, let the baby suckle.
The sucking is there. What we are worried about, there is swallowing reflex is not developed till 34 weeks. So there may be problem with suck swallow. So at that time, we better give sucking. In that case, we give non-nutritive sucking. If mother is confident, that is very individualized. If mother is confident and caretakers are very confident, we can try breastfeeding also, ma'am. There's no issue. That depends on the confidence of the mother.
Of course, and it varies baby to baby. It's different.
Yes, ma'am. Points very well taken, sir. We come to Alka, ma'am. Ma'am, what are the legal implications of prescription of formula feeding? And what is the IMS Act? What every private practitioner should know about?
Yeah, very important question, because few years back we had conducted survey, and hardly few doctors knew about staff. Hardly few doctors knew about what is IMS Act. And they said, on which you want to talk on? We have not heard about IMS Act. Obstetricians, even the senior obstetricians were not knowing about IMS Act. So very important question now, because of the constant work by the BPNI members and our own colleagues. Most of the people, they know about IMS Act, but the question is, what is the legal implication? So basically, IMS Act controls, rather regulates production, supply and distribution of infant formula, infant milk substitute and feeding bottles. So it is regarding the regulation or controlling authority. And if the violation is there, BPNI, Akash, Central Supervisory Board, Child Welfare Board, these are the 4 gazetted organizations to whom you have to report violation. There is imprisonment and fine or fine. So fine can be ₹1,000 and imprisonment of 1 year or 2 years, rather 2 years. And if the subsequent offense, again they have committed the same offense, then fine of 5,000 and 5 years imprisonment. So these are the legal implication if one doesn't act according to the provisions of the IMS Act. So what are the provisions of IMS Act? Overall, it says that if without indication, without prescription by pediatrician or the health care provider, if any inducement of money or sample or any promotion of milk, infant milk formula, infant food, feeding bottle is done, or sending them inducement to the health worker that she will be given travel to from Nagpur to Bhopal or something like that, or doctor is said your whole hospital will be given good painting, or your company will sponsor your CME. So even the mother, that if you purchase infant such formula, you will get clothes for your baby. So all sorts of inducement to the mother, to the health worker, including doctor, in terms of money, in terms of free samples or gifts. If it is made by anybody, then he is liable for punishment. So it is in true sense, not only by word, but only by spirit. If it is indirectly affecting breastfeeding, what is the main purpose of IMS Act? To promote and protect breastfeeding from commercial onslaught, from commercial or media. So unnecessary use of formula, infant food and bottles. Bottle we say in Marathi, putana maushi. Once we start bottle, then all the breastfeeding is hampered. So, and even bottle is not good for anybody, whether the child or the adult, all these things. Just because to have impact, we talk like this in our webinars or workshops. So all these things are controlled by IMS Act, and it was amended in 2003. Doctors, it is a parliamentary act made by government. So it is very strict act. If you have to inform, you can inform to the authorities, and even you can inform by your unknown name. So no need to write your name also. And the this Dipen and Akash, they confirm it that some doctor has violated the act, is liable for punishment, imprisonment, and fine. So unnecessary introduction of formula, infant food, feeding bottle, all these things are controlled by IMS Act. Unless and until it is advised by pediatrician or the healthcare provider, where there is true need of infant formula. But with the advent of human milk bank, again, human milk bank is next to mother's own milk, that we'll be discussing in the next few questions. So IMS Act is a regulatory body, parliamentary act. If anybody violates the act's provisions, liable for punishment and fine, of course. So nobody should give sponsorship for any CME, for a travel to abroad, any samples of all these infant food formulas, any painting of your davakhana, or any clinic painted by this IMS. And which companies? IMS or infant food or bottle producing companies, because they are playing with the child's health. Indirectly, they can get us to child morbidity and infant mortality because of the introduction of formula, food, and bottles. So all these things are controlled by enactment of Parliamentary Act, IMS Act. That is infant milk substitute, feeding bottle, infant food, regulation, manufacture, supply, and distribution Regulation Act 1992 got amended in 2003. This is in short, otherwise it requires one lecture for IMS Act. Am I audible? Was I audible?
Yeah,
Yes,
yeah.
ma'am.
So this is in short because it requires separate lecture for IMS Act. And now because of constant hammering, the OBGYN, of course, pediatrician, they know about IMS Act. Otherwise, 10 years back, when I got that form, filled by the OBGYN people, hardly 10% knew about IMS Act. They were not ready to keep lecture on IMS Act because it's very, I don't know about that. They said like that. But when they heard about the IMS Act, then they came to know that we should not play with the health of the child. It will indirectly affect our child morbidity, infant mortality rate, and the future of the India, future of nation. Because our child should be strong by health and by intellect.
Sure, ma'am. I'm very happy to announce that IIT does not endorse any of these, and we were speaking to Kinjwalkar sir a few days back before when we were doing the breastfeeding webinar. He has endorsed that any other product that the company is manufacturing, even then they will not endorse that company. So, for example, if they're manufacturing vaccines, then they do not even take grants for their conferences. I think even obstetricians should come to this in order to promote.
We have answered about company, Nescafe. This company is about. There was some, it gave rise to that death of the child because of some bacteria. Some bacteria was there, and because of that, it was totally banned. About company. Again, Nestle. These are the companies against whom litigation was there by BPNA, and BPNA has won the case. So all these things should be known to obstetrician and of course pediatrician, because both OBGYN and pediatricians, they have custody of the child for the welfare of the child, of course.
Sure, ma'am. Your points were very well taken. Let's move forward. Dr. Arki, what is a baby-friendly hospital and what are the essential components of it? And how can a hospital be accredited for the same?
Madam, baby-friendly term is very official description of any institute or hospital which has taken an initiative to implement practices that protect, promote, and support breastfeeding as a global effort launched by the WHO and UNICEF. Thus, this type of hospital, which is baby-friendly, encourages promotion of healthy feeding choices for the infants. The IMS Act should be strictly followed in such type of hospitals, and all the checklists provided by the UNICEF or BPNI, they should be followed, and the hospital should conduct the assessment internally, and then the BPNI or UNICEF persons are invited for the assessment. The 10 most important components of any baby-friendly hospitals are the mother in such type of hospital, the mothers in different wards like ANC ward, PNC ward, and the OT, they are very well counseled for the breastfeeding practices. The first most important component of baby-friendly hospital is the hospital should have a proper policy that the hospital supports mothers by making breastfeeding care standard practice and by not promoting infant formula, bottles, or any type of teats. The second component is making the hospital staff very competent by training them on supporting mothers for breastfeeding and also by assessing health workers' knowledge and skills about breastfeeding practices. The third component is the mothers are counseled in ANC visits about the breastfeeding practices and the importance of the breastfeeding. The fourth component is the hospital staff should provide care right after birth. That means engaging skin-to-skin contact between, encouraging skin-to-skin contact between mother and baby soon after birth. The fifth component is to support mothers for the breastfeeding. That is by checking the position, the attachment, and the suckling of the baby. And mothers are also helped with by addressing their common breastfeeding problems. So they are mothers are to be taught how to take care of their breast, and if there are any issues regarding feeding problems or any conditions that is restricting babies for breastfeeding, that should be addressed by the hospital staff. The sixth component is to provide supplementation to the needy. Meaning thereby that if the mothers are having some medical reasons for not breastfeeding their babies, the hospital should try for the donor human milk on priority basis as a supplement to the babies. And if the human milk bank is not available, then the mothers are helped by the hospital staff who want formula feed to do that practice very safely. The seventh component is there should be rooming in that, meaning thereby that the mothers and the babies are made to stay together day and night, and even if the babies are sick, the mother should stay nearby to the baby. The eighth component is the feeding should be responsive. Means mothers are educated in knowing when their babies are hungry. The usual scenario in PNC wards are that the babies are crying and then the mother is addressing the issues of breastfeeding. But that is not the proper timing. That is too late. If baby is crying for because of hungriness, then that is a very late sign that mother is identifying. So the early cues of breastfeeding, early cues of hunger should be taught to the mother. And also the mothers are not, breastfeeding time should not be restricted. Demand feeding should be given to the babies. The ninth component is mothers are counseled on use and risk of feeding with bottles, teats, and pacifiers. The 10th component, which is most important component, is that during discharge of the mother from the hospital, the mothers are referred to the community resources for breastfeeding supports. And the hospital should also coordinate with the communities which are acting as support groups for the mothers in the periphery. These are the basic 10 components of the baby-friendly hospital. Then how we should apply for the baby-friendly hospital accreditation. There are this is a very long procedure and involves thorough site visit. So it takes almost 2-3 years also for getting our hospital as a BFHI accreditation. Under MA program, which was launched by the Ministry of Health and Family Welfare, Government of India in 2016, guidelines are issued for the BFHI accreditation. In that, we should first train our staff in breastfeeding practices. Resensitization of the staff should be undertaken at frequent intervals. The OPD, ANC ward, labor room, PNC ward, and immunization clinic and pediatric OPD staff, doctors, all, even ward IA attendants, they should be trained in breastfeeding practices. Various checklists are discussed in the training session, because the checklists are issued by the Ministry of Health also, and also by the BPNI and UNICEF. The need-based trainings to be arranged with the help of BPNI members. Then internal assessment to be carried out as per the checklist. The gap and the gap closure and the compliance submission to the BPNI and the UNICEF consultant is the next step. Then various proformas to be filled for collecting the information about breastfeeding practices. The hospital should submit various proformas and should collect all the information and should send to the BPNI. The main proformas which are to be submitted are successful breastfeeding 10 steps, whether the hospital is following basic 10 components of the BFHI. Then second is infant feeding record, that is practices of breastfeeding after delivery. How the labor room is, how the practices are going on in labor room, OT, and even in PNC wards. That information should be submitted in the form of checklist. Then training information about IYCF, that is infant young child feeding practices. Fourth is hospital information about BFHI implementation. Fifth is breastfeeding policy checklist, that is the hospital should have its own breastfeeding policy. Sixth is information about mother's knowledge of breastfeeding. All these proformas and the information should be collected and should be sent to the BPNI. The assessment by the BFHI trained officer should be scheduled after compliance of all this information to the BPNI. Then gap identification and the gap closure compliance should be submitted. And then the visit by the BPNI members and UNICEF consultant as a pre-final assessment process to be initiated. Again, we can get the gaps after the pre-final assessment, and then we should try for the closure of the gaps, and then we should schedule for the final assessment by the BPNI and the UNICEF consultant. The assessment is done mainly in labor room, OT, as per the checklist. Then as per the checklist, practice of breast crawl is observed. Then breastfeeding practices in PNC ward, both normal delivery PNC and post-dialysis ward is carried out. Then breastfeeding practices assessment is done in SNCU and MNCU, that is mother and newborn care unit, where KMC checklist is assessed. Then breastfeeding practices in NRC, that is Nutritional Rehabilitation Center, where SAM babies, severe acute malnourished babies, are admitted for 14 days. The practices of breastfeeding are assessed as per the checklist. Then breastfeeding practices are assessed in Hirkani Kaksha also as per the checklist. And the breastfeeding practices in immunization clinic in the form of 4D audit. That is 4Ds are diet audit, developmental milestone monitoring, then drugs audit, and the doses of vaccination audit. The BPNI and the UNICEF, all the officers visit all these sections of the hospital and assess the breastfeeding practices and knowledge of the staff, skills of the staff, and also the knowledge of the mother and the family members. These are the steps for any BFHI accreditation. So it's a very lengthy process. Many trainings are to be scheduled for the. Hello.
Can I add something?
Yes,
Yeah,
madam. Yes, ma'am.
Yeah, because BPNI Maharashtra, we do this BFHI certification, and it is not complicated, as said. Basically, we give the training sensitization first half day, and then 2 days we do the evaluation of the hospital. At the same time, we go to all parts of the hospital and we see what the practices are, and then we just give them the paper saying what practices you need to improve. Like, whenever we go for BFHI visit, they all want to say, ki goody goody, we are giving only the breastfeeding because they want the certification. So recently we went to one of the hospital and they said, no, we don't give formula at all. I said, it is not possible. 100% no formula, it is not happening. Few babies, they always need formula for some reason or other. And then they had a deliveries about 50 deliveries per month. And then we visited the pharmacy there, the shop, the medical shop. And we saw, we asked them, how many formula dibbas are sold per month? And they are selling 60 formula dibbas per month. So that means more than one dabba actually is given to per baby. So when I showed them these statistics, the HOD was so surprised how this can happen. And when we are saying yeah, all breastfeeding is happening, but it was exactly the opposite. And we know situation going around because we interview mothers, we interview staff, we interview Maushi Bais, everybody's, and we come to know what is the practices. So then we just give them 3 months time. You improve those practices. We go back again after 3 months. And if they are genuine and they have improved the practices, yes, we along with UNICEF, we give them the certificate. So it is not that difficult, but I think the staff training is very important. The directors, the administrators, the HODs, they all have to have the knowledge. So they have to make sure the audit is going on. How much is the initiation actually happening? How much exclusive breastfeeding at the discharge happening? These two are very important sentinel indicators that we see what is happening in the hospital. So sure, कुणाला पण जर पाहिजे असेल BFHI certification, it's actually very prestigious certification, and by that your hospital will get more patients also once they know that you are breastfeeding friendly. So you let us know and we will visit your hospital and we will help you out for that. Thank you.
Thank you so much, ma'am. Our next question is for Dr. Vandana Gandhi, ma'am. How do we tackle sore nipples and engorged breasts?
I will talk about the sore nipples first. There are certain causes to get the sore nipples. Sometimes mother's skin is very dry, so it should be well lubricated also, and it should not be under dehydration. She should take enough water and enough liquids. Second thing, sometimes the baby's latch is superficial, so the baby's hard palate is in contact with the nipple, and that hard palate gives a very rough grip, and it may cause superficial cracks and sore nipple, which increases the mother's pain and discomfort, may reduce the milk flow also. Third reason is sometimes babies during teething period. That time also baby strives for the milk supply. At that time, it can cause dry and sore nipples. So the cracked sore nipples is a constant source of pain. And to avoid that, mother can apply her own milk. That is said to be very comforting as well as very much antiseptic to the nipple, so that they should not get infected. Secondly, in between the lactation or in between feeding time, she can apply coconut oil or cow's milk or lanolin ointments, which help to soothe her nipples so that the next feeding will be comfortable. So the superficial crack should be taken care so that they don't become very deep crack. And even if they are cracked, she should extract the milk so that they will not invite infection to go ahead with the breast abscess or mastitis. And about the engorgement of breast, breasts are said to be engorged when they are not fully emptied or there is excess milk flow, and they are full of milk and they become tender, warm, and very much painful. If these engorged breasts are not emptied frequently or not, the milk is not removed by feeding, or if there is excess flow, they should be removed by massage, as well as may need breast pump to evacuate the milk. So continuously milk flooded breasts become engorged and very much painful. For that, mother can use moist towels or napkins to give soothing effect for 10 to 15 minutes, and then she should massage from chest wall towards the nipple so that the breast milk is expressed, and then she should be encouraged to feed frequently so that the milk is emptied and the engorgement becomes less. The engorged breast should be given priority for feeding. That should be fed first so that the milk is reduced. And for some time, if there is severe pain after feeding, she can also use cold fermentation so that the temporary milk supply will be reduced and she will get comfort. But frequent feeding is encouraged to avoid the engorgement. They should not be headed towards mastitis and infections because of the both reasons of cracked nipples as well as engorged breast.
Can I comment,
Yeah.
Monica? Can I comment?
Yes, ma'am.
First of all, the root cause should be removed. What Vandana said correctly, proper latching on will prevent crack from happening. But the most important thing we need to tell to the mothers, we tell them you should have cleanly hygiene, rather proper cleaning of your body, etc., etc. What they do, they apply soap water to clean the breast. They try to squeeze the whatever secretion is there. So because of the application of soap water, what happens? The oily glands are there. They secrete sebum to keep the areola and the nipple area smooth. But because of the constant washing of that oily substance, because of the application of soap, it becomes dry and becomes a needles for infection. And it's very liable for infection. And again, because the proper latch is not there, baby pulls on nipple suckling is there. Again, that is reason for creation of the crack nipple. Third thing, the two things I had told. Third thing, when somebody comes to your house, what the mother does, suddenly pulls the baby away from the breast. So we should teach the mother, the person who has come is giving just call bell, he can wait for a while. But always insert a small finger in the karanga you want to open, inside the baby's mouth, release the suction. We keep the baby away from it, take the baby away from the breast, and then go towards the door to open the door. Otherwise, what she thinks, the person will be angry or whatever, she suddenly takes the baby away from the breast. That pulling of the over the breast or over the nipple can give rise to cracked nipple. And again, fungal infection of the breast or nipple can give rise to crack. So the root cause to be removed. And second important thing about engorgement, Vandana has nicely said, frequent emptying, warm compress before expression of manual expression method need to be taught to the mother before discharging the mother. Because initial 5 days, milk supply is adequate, means the baby takes that much milk. But after a few days, there will be increasing milk supply. If the milk is not removed by the baby because of less need or because she is not feeding properly, milk will get accumulated. And because of the accumulation, there is local inhibitory substance that is there inside the acini, the cells of the lumen rather, is a negative local feedback mechanism that inhibits the milk production to avoid the injury to the breast. So it is a self-defense by the cells of the acini that controls milk production because there will be damage to the cells of the glands of the breast. So, and again, negative feedback, the more milk, less that there will be less order by the higher center to prolactin and all this. This is negative feedback we know. But the third thing, we can apply cabbage leaves like in between breastfeeding. So hot compress just before expression, cold compression in between breastfeeding so as to relieve the engorgement. And cabbage leaves have proved very useful. Of course, we have to clean the cabbage leaves. Clean cabbage leaves, if kept in a freezer, we can the mother can be taught how to keep, because the shape of the cabbage leaf is such that it fits to the breast. So because of the cold compress also, there can be less of edema, less of pain, and some, if the mother doesn't tolerate the pain, mild analgesia can be given to the mother. It will relieve the pain. And the important thing is that cracked nipple should be prevented, because if the cracked nipple is there, it's the vicious cycle. Milk goes on increasing and it is not removed. Engorgement, milk mastitis will be there, abscess will be there, and we know now that we encourage like in syringes, we use syringe to drain the abscess. But previously, what they used to do, incise and drain the abscess. So incision and drainage, again there is a wound. Sometimes the breast milk ducts are cut because of the wrong incision on the breast. And all this, again, this is like a memory, bad memory for the mother for the next child. She will never forget such incident of inciting the breast for drainage of the abscess. But if at all abscess is there, we give wide course of antibiotics and apply syringe method to drain the abscess. So these are the three things: cracked nipple, engorgement, mastitis, and abscess. We need to teach our mother so that they will not let cracked nipple first happen. Even if there, they will try to rectify the situation. They will not allow engorgement and of course the mastitis and the abscess, the miserable condition of the mother. By that, she will never try, she will just forget breastfeeding in the next delivery because of the bad memory or bad experiences with her.
Usually this engorgement happens when there is a transition of colostrum to proper milk expression. So
Yes,
that period we discharge the patient, because on normal delivery we usually discharge second or third day, and for cesarean we discharge on the 5th day morning. So in that period when the milk supply is increased and the colostrum is shifting to milk, at that time the engorgement is more risky. So that should be encouraged.
We should teach them before discharge because nobody is going to teach them at home, no? So always teach them so that if it happens at home, the excess milk supply, but baby doesn't need that much. So they can at least empty the milk, either keep it, if she is working woman, she can, the person who is in home, he or she can give the same milk if she's a working woman. So at least she will remove the excess milk. The new milk production will be there. Otherwise, engorgement, mastitis, and a vicious cycle will go on. Yeah.
You said about the cabbage leaves, madam, whether there is some action of cabbage itself or it is the shape and application easy because of the leaf are flexible like that, or is the cabbage acting?
There are two effects. One, the shape of the cabbage, it is like concavity, no? It fits properly to the breast shape. And second important, the substance of the cabbage. The whatever is substance of the cabbage leaf, that cause relief in edema, swelling, interstitial edema, that is relieved by application of cabbage. That is a cold cabbage leaves, not too chilled one. Whatever she can tolerate, accordingly the cabbage leaves can put on the breast so that it will relieve pain, edema, swelling, everything. And
So cabbage has a medicinal value, what you say?
Yeah, we have tried that. And during expression, of course, she can take warm water bath, do a little bit exercise. This is actually taught in antenatal classes and before discharge. There are different steps of how to milk should be removed. Different steps are there. And then they can remove at home, provided milk supply is more as proportion to the need of the infant, baby.
Thank you, ma'am. We now come to Dr. Mangal Rathi, madam. How will we counsel and treat a breast abscess? Part of it we've already covered. Ma'am, can you elaborate on the remaining steps now?
Breast abscess, you have asked me.
Ma'am, Dr. Mangal Rathi.
Yes. Counseling of a patient, we should counsel her to maintain breastfeeding for a recovery and for infant growth. She should continue feeding with both breasts if she can. It does not affect the outcome of treatment provided. It helps to empty the breast as thoroughly as possible and avoid breast milk building up in the breast. If it is too painful to breastfeed directly, then try pumping or hand expressing as just discussed. The milk from that breast may be given to the baby without pasteurization if it does not contain pus or blood. Continuing breastfeeding does not present any risk to the nursing infant. And now, treatment of breast abscess. The first most important is ultrasound guided drainage in combination with oral antibiotic is the effective treatment for breast abscess. Needle aspiration may be attempted for abscess smaller than 3 centimeter or in lactational abscesses. Non-lactational abscess have a higher rate of recurrence and often require multiple drainage procedures. Incision and drainage have lower recurrence rates, but they are more invasive than needle aspiration and may lead to scarring and possible pure cosmesis. If there is a recurrence of an abscess after aspiration, hello? Am I audible?
Yes, ma'am, you are audible. You can continue.
Incision and drainage should be performed. If there is a large cavity, follow incision and drainage. Packing of the cavity may be done to promote further drainage and prevent the skin incision from healing before drainage is complete. A course of antibiotic may be given before or following drainage of breast abscess. There are many options for treatment. The consideration must be given to the possible pathogens involved based on the patient history. It is also important to consider if the patient is breastfeeding and whether the antibiotic given are safe in breastfeeding patient. Culture should be obtained to guide antibiotic therapy, especially in the... Hello? Hello?
Yes, ma'am, you are audible. You can continue.
Some of the antibiotics to be considered are nafcillin, augmentin, doxycycline, trimethoprim, clindamycin, and vancomycin. Antibiotics may be required for 7 to 10 days. Patients with large breast abscesses or signs of sepsis should be considered for admission to the hospital. Large breast abscess may need incision and drainage in the operating room, packing of the wound for healing by secondary intention, and possibly intravenous antibiotics. Pain control with non-steroidal anti-inflammatory drugs and or prescription narcotics should be considered. Adequate breast support must be provided. Emptying of the breast. The breast may be emptied either by suckling or by manual expression or by pump. And last, continuous breastfeeding does not present any risk to the nursing infant. So continuous breastfeeding should be promoted. That's my answer.
Vani madam, do you want to elaborate any further?
No, she has elaborated quite beautifully. My experience now, more than 100 mothers aspirated breast abscess, because ours is a referral lactation clinic. Any size of the breast abscess we can aspirate, though the research says only less than 3 or 5 centimeters. In fact, the larger the abscess is more easier. We used to do with ultrasound first, guided needle, but now with the experience, we just do without ultrasound. And we may have to do multiple, because abscesses can be multiloculated. So in one sitting, it may not happen, but we have beautiful, like 98% success rate. We are about to publish the paper on that. And I think incision drainage is not the option anymore now for the breast abscess. Any size of the breast abscess, lactational breast abscess.
Sure, ma'am. We will be waiting to hear from you regarding the paper, ma'am, so that we all can also start.
Just nearly 7 o'clock. I will just answer one more question. I have to go for the emergency.
Sure, ma'am. Yes, ma'am.
So I think.
Could you finish your talk about the induction of lactation also, ma'am?
Yes. So that is again important thing about the induction of the lactation.
Monica, just one, Mangalavani madam, just one thing regarding breast abscess, then you can continue. Many times, what is the practical question asked by the mother? She has got breast abscess, then she wants to know whether she can breastfeed on the particular breast. This is the question usually asked. So we have to tell if the breast abscess is localized on the nipple or areola, where the baby latches on, she should avoid breastfeeding on that mother, but express the breast milk from that breast, because otherwise it will again give rise to vicious cycle. But she can breastfeed on another breast till the area is healed. But she asked whether she can breastfeed the baby even if the abscess is not there, whether the abscess is harm the baby. The abscess is localized inside the cavity. There is a localization of the breast. There is a sac is there. So anyway, abscess will not go into the baby's mouth through breast milk, because it is a sac enclosed inside the sac. So the mother is afraid of whether by breastfeeding on the same breast where the abscess is located away from the nipple and areola, whether the baby will swallow abscess or pus. That is the fear in their minds. We should tell them abscess or pus doesn't go into baby's mouth as it is localized in the sac. But of course, if the abscess is located over the nipple and areola, then she has to breastfeed on another breast. But important thing, breast milk needs to be removed so as to avoid the vicious cycle. That only I wanted to add regarding practical difficulty when the mother asks whether to breastfeed or not on that particular breast.
Yes, yes.
Sure, ma'am. Thank you. Vani ma'am, we can now hear from you regarding the induction of
induction of the lactation is when the woman is not pregnant and she has not delivered the baby, but she has adopted the baby or she gets the baby via surrogacy. Then even if she's not pregnant, she can breastfeed. We can induce the lactation in them, and because the benefits are so much, and the satisfaction and the bonding between her and the baby and mother, they both get benefited from that breastfeeding. And success is quite good. But you see, in normal pregnancy, it takes 9 months for that breast to prepare for the breastfeeding. There is a proliferation of those ducts, and then the glands happen, the proliferation, and then the secretions start happening. So similarly, we had to at least 6 महिने बाळ यायच्या आधी, 6 months before the expected baby coming, we have to start the process. Now there are different protocols with the time constraint. I will just tell you the basic, and that is the gold form Newman's protocol. So we give first hormones like estrogen and progesterone for a few months. Along with that, we give the galactagogue, and domperidone is the most commonly used galactagogue we use because it doesn't cross blood-brain barrier and it has no side effects like depression and all. We don't use the prochlorpromide like perinom and all because we cannot use it for longer time, and it crosses the blood-brain barrier and it causes depression in the mothers. So use domperidone, very safe. We use higher doses, up to 120 milligrams even we give. And we have to explain to the mother that this is purposefully higher dose we have given. And then we give domperidone, and just 6 weeks before baby's arrival, we stop this estrogen and progesterone. It is like delivering the placenta and the mother's estrogen progesterone level falls. And then we teach her to start pumping. So there is a stimulation of the breast, and then in few days she sees the few drops coming, and by the time baby comes, actually she will have 20, 30, 40 ml coming, in the expression. And so this is the preparation, milk production, but the most important afterwards is directly the latching. We have to make sure how much milk baby is getting, whether baby is getting enough milk, and the family support. We have to tell the hospital staff, yes, she's not pregnant, but she can breastfeed. We have even twins, breastfed for 15 months. And just 2 weeks ago, one mother came because she breastfed for 2.5 years and she wanted to wean off the baby. So she wanted actually the medicine to stop the breastfeeding. So success is good, but how much committed the mother is and how support the family is, that is very, very important. It may not be 100%, but the satisfaction that the mother gets, that the baby is so close and this baby's breastfeeding, it's tremendous. So it is a science and it is a skill itself. But all health professionals, they should be aware of this, and they should refer, their patient in advance to that lactation consultant or trained health professional, whoever they are doing this job. And we need the pumps which are hospital graded pumps, not the small manual pumps or not small electric pumps, because the stimulation of the breast is very, very important. So that is it's Monica. Monica's internet is.
Am I audible now?
Yes, you are.
Yes, ma'am. Yes, ma'am.
Ma'am, thank you so much for being on board with us, and you have clarified a lot of doubts all of us had. I wish we have many more sessions for all the obstetricians across Maharashtra through the AMOF Public Awareness Committee with you, ma'am.
Let us do that.
Yes, ma'am. Definitely, ma'am. Thank you, ma'am, for joining us.
Yes. Thank you. I had to leave a little bit early.
Yes, ma'am. Yeah. We now move forward to the next question by Dr. Samant Tamburi. Please share the protocols and drugs commonly used in suppression of lactation, and in which situations is it required? Saman, you are not audible. Please unmute yourself.
Yes, ma'am. Thank you so much, ma'am. Lactation suppression is usually done in scenarios where mothers have lost the baby. Either it's an intrauterine fetal demise or immediately after birth. the baby has expired, or the mother has fed the baby for some time and then the baby, she has lost the child. Or it could be because the baby has been put up for adoption, or it's a surrogate mother who has given up the baby, and now she doesn't want to have the breastfeeding going on. So for lactation suppression, earlier what they used to do in the early 20th century was they would bind the breast tightly. Some would use only some would use cabbage leaf application, and pyridoxine was given, and bromocriptine was also given for some time, but then later they observed a lot of cardiovascular side effects. Patients are getting myocardial infarctions, stroke, etc. They also give high dose estrogens to suppress lactation, but none of that is being used now. Now, the most safe drug that can be given is cabergoline, which is an inhibitor of prolactin, and that is given immediately. That is given in the dose of 0.25 mg. 2 tablets are given stat, and the action begins within 3 hours. And we do advise that the breast should be well supported, and in case they get engorged, ice cold application should be done. And the most important thing that you should tell a mother who wants to suppress her lactation is to stop stimulating the breast. What happens is we get patients who suddenly stop feeding the babies when they're weaning them, or for whatever reason the breasts get engorged, and then they continue to remove even when it's mildly engorged, and they keep removing the breast milk. So this needs to be taught to the patient that if you continue to remove, the breast milk will continue to get built, because that is how the feedback mechanism works with breast milk. So minimize the nipple stimulation, wear tight brassieres, well supported brassieres, and in case even after doing these measures the breasts are getting engorged, then we can of course you give some analgesic and give chilled cabbage leaf application, cold fomentation. And it is very important to counsel the mothers in these cases. Actually, bereaving mothers are the most difficult mothers. They need to be given a lot of emotional support. In the West, some mothers who have lost babies are also preserving the little bit amount of breast milk that they have before beginning the lactation suppression. They are using that milk during funerals. They are converting it into jewelry, because the emotional trauma that they're going through is a lot. And some women feel that they are, when they start weaning, or maybe they have stopped giving breast milk to the baby for whatever reason, due to maternal illness, like in HIV positive mothers. We don't advise them to, who are not on ARV, we don't advise them to breastfeed. So they feel that they are less of mothers. So a lot of psychological support should also be given to these women, that you're doing this for because everywhere we're saying breastfeeding is important. But for these women, it's actually, in this specific case, they might harm the baby. So that support should also be given to these mothers, that it's not they should be mentally strong enough that by not feeding also they are doing some good for their child.
Two things I would like to add. Dr. Saman has nicely told how they can remember their child's death rather, or memory. So ornaments she added, but some mothers like to donate the milk to the milk bank, so that they feel that some good work is done by them. Though they have lost the child, their milk will be used by another needy child. So that will heal their the trauma, mental trauma that will get healed due to the donation of breast milk for the other needy child. An important thing what you said, I think I should comment on this. HIV mother, we don't advise don't breastfeeding. We do a lot of counseling. We know all those APAS criteria. Nowadays, APAS criteria also doesn't hold good. The endemicity of the disease in the country, how many percentage of HIV positive, are all these factors to take into account. Counseling is done and choice is given to mother, whether she wants to breastfeed, even if she is HIV positive. And all we know that the drugs are given in the last trimester, so as to decrease the transmission, and afterwards encourage breastfeeding after proper counseling, what she prefers, either totally top milk or complete breast milk. And again, important is that if she has mixed breastfeeding, that can increase the chances of HIV. All these things we teach. But important thing is that anything can be explained to the mother, except that don't breastfeed. If you say don't breastfeed, it will be totally against her emotion. So a lot of counseling is required in HIV positive mother. The recent guidelines tell even if she breastfeeds the mother, Because in India-like countries, there are more chances of malnutrition, diarrhea, septicemia. The babies can die because of that. If the mother totally switch over to top feeding. Instead, if she breastfeeds the baby, even if she is HIV positive, with the proper drugs given to the baby at the birth, proper drug she is also receiving since antenatal period, the chances are decreased, and of course the child will survive a lot than the totally top fed babies. And again, there can be sudden, previously they used to do slowly weaning. I should not use weaning, the word weaning. Complementary feeding, abrupt stop, they can start the top food or top milk rather. But breastfeeding advantage can be given in HIV positive mother as well. But of course, after proper counseling, what is the pros and cons of breastfeeding? Even though she is positive, pros and cons of top feeding, even if she feeds the baby with top milk or animal's milk or formula. In that case, formula is given, humanized formula is given. Of course, it goes to pediatrician's domain. They advise as per the requirement of the baby. But we can't say that HIV breastfeeding mother can't breastfeed in a today's era.
Yes, ma'am. Can we now come to Dr. Kundan Chopre? What advice will you give for breastfeeding in a sick newborn, and what is your advice for vaccination?
Regarding the sick newborn, the newborn which is having not hemodynamically stable, who is having respiratory distress, circulatory insufficiency, and CNS depression is there, the breastfeeding is not advised. At the most, we can, when the patient is stable, we can start breast milk. That can be given as a orogastric or nasogastric feeding. And if minimal oxygen requirement is there, with oxygen, we can give breastfeeding to the baby. This is for really sick newborn, the breastfeeding is not advised. Regarding your second question, vaccination, this is very important. I advise mothers that the vaccination, first vaccine for baby is the breast milk that she is to give. Then 3 vaccines are important in first few days of the life. That is BCG, then OPV and hepatitis B. Then previously there was a concept, this concept was there that there is immature immunity of the newborn. That's why the vaccine will not take, uptake will not be good, and vaccine will be wasted if given earlier. But now there are very well studies are there, and there is WHO work paper is also there that BCG can be given even after 31 weeks of the baby, and there is good immunity is there. It is T-cell mediated. And then other vaccine is OPV. This is 0 dose OPV we give as a priming dose only. And that third important message I want to give by this platform is that hepatitis B vaccination, it should be given to all babies born. Previously used to give on day 1 to only the mother who are HbA positive along with immunoglobulin. But now hepatitis B vaccine is recommended to all babies, irrespective of mother's HbA status, and a vaccine should be given within 24 hours to prevent vertical transmission. That is very important, and it is most of the time on day 1 baby is in maternity home only. So day 1 the vaccine should be given, and it is freely available in government setup. We can ask our attached PHC or urban health center, whatever is near to us. They will give the vaccine to our setup, and along with vitamin K, it should be given to all babies within 24 hours. And that is regarding vaccination in newborn period.
Thank you, sir.
Can I have one question to Dr. Kundan, please?
Previously, criteria like weight, 2 kg, 2.5 kg. Now, if the baby is clinically stable, we give vaccine to all babies irrespective of its weight and gestation. And previously, we used to calculate vaccine according to chronological age. Means we have to calculate 1.5 months from the 42 days from the expected date of delivery. But now we can give as per his birth date. Yes, ma'am.
I have one question to ask. In some patients, we don't get enough milk in first 3 days. Very scanty colostrum also. And at that time, I have heard pediatricians who visit that there is hypoglycemia and either give IV glucose. So instead of that, in some restricted cases, can we start the lactogen 1?
What
So
happens,
initial, because baby is not hypoglycemic, then only baby will suckle, and then only it will not cry, and then only mother can be confident to feed the baby. With a ill baby or baby is hypoglycemic or baby going to ICU is a trauma to mother which will hamper the lactation. So why not to give 1 or 2 days to start with, especially cesarean mothers?
No, ma'am.
So
What we
first breastfeed and then give some top so that baby is also well fed and baby have energy to suckle.
yeah, ma'am.
Dr. Kundan, you please
Yeah, yeah.
explain. Yeah.
Yeah, what is we advise is exclusive breastfeeding, and whatever colostrum, whether it is in small quantity or whatever breast milk is there, that will be sufficient for the baby. And there is as such no risk of hypoglycemia. Whatever we have to look for the signs of feeding, whether it is adequate feeding, whether baby, most important, we can ask mother that after breastfeeding, whether baby sleeps for 1 or 2 hours or not, whether the cry is, how is the cry of the baby. You have to look all these factors, whether you have to look also urine output of the baby, and whatever milk is there, that is sufficient. Most of the time problem is with attachment, latching, and not proper feeding is the main problem. And giving, as we have discussed already, giving top milk is not the solution. What happens if baby gets top milk, then mother also becomes reluctant to feed also, and her breast milk also decreases. As we have seen, thus prolactin secretion is more when we baby sucks the nipple, there is more and more prolactin secretion is there, and milk secretion reflex is there. So it is not advised to give formula milk for 1 or 2 days also.
So I think I would like to one addition to that, what Dr. Kundan sir has said. Actually, this is a myth. It's that baby will be hypoglycemic. It's a myth. Baby is never hypoglycemic, even if the colostrum requirement is less or less amount of colostrum is there, because it is highly rich in lactose. The important sugar in milk, human milk, is lactose, and that is insufficient. It is a tailor-made. We say it is a nature's gift, tailor-made as per the requirement of the baby. So whatever glucose is there, it is in the form of lactose. We know we always ask which milk is sweeter, more sweet rather. Perhaps the audience says buffalo's milk, cow's milk. Then we have to answer, it's a human milk that is more sweet than any other milk. So that much quantity of lactose or sugar is sufficient for the baby's routine. And again, what we were saying, we should know early feeding cues. So we should not let the baby cry. Crying is a late sign. So we should know baby is doing cooing, like looks at the breast, moves her hands as if she wants something, baby wants something. These are the early feeding cues. If you want that baby sleeping since a long time, wake up the baby, remove the blanket, remove the towel, whatever, remove the clothes, just what we say, slowly, like limbs should be like a touch, so that make the baby alert. Remove the that langot and everything, what we did, dupta already. So we wake up the baby, and before that, know the early feeding cues, so that you know, even before crying, the baby needs mother's milk. So the skin to skin contact, frequent feeding, prolonged feeding, night feeding, all these things are very important. Even if the mother is LSCS or cesarean mother, we can have the baby in her left lateral side, any side. Even there comes the role of mother support or family support, where the mother of the patient has to take the baby with the mother, so that though she is having pain, as for nowadays good analgesia is there. So the pain can be relieved. Mother can skin to skin contact can be there. Even cesarean, we hold the baby like this. So the first contact is given in the OT, first touch. That touch, like kissing of the baby, all this gives rise to oxytocin. It's called love hormone, bonding hormone. So whatever milk is produced, it will be secreted and given to the baby. So all these things are very important in antenatal counseling. We teach the mother when the first touch should be there, breast call is there. All these things needed to be taught in antenatal counseling. And first touch after the mother as early as possible, even in cesarean delivery, and removing the myth even from the OBGYN and some pediatricians, I should not say pediatricians, because they know the basic things. But I have seen some pediatricians giving formula or even I can say formula or other things that they prescribe on the paper. I have seen the prescription from pediatrician as well. The baby will be hypoglycemic, give this to baby, otherwise baby will be sick. On the contrary, mother should be taught to hold the baby skin to skin even after cesarean delivery. That touch will stimulate secretion. That will release the milk, whatever is produced in the mother's breast. No risk of hypoglycemia at all. And of course, if the winter is there, rainy season is there, baby should be properly wrapped. So as the hypothermia should be there because of the temperature loss, not because lactose is less. Lactose is in sufficient quantity.
In normal deliveries, I used to practice to stand by her mother's mother, means the grandmother, to take the baby for feeding till we do the suturing of episiotomy. So that is
Yes.
also a good practice and early initiate. And at that time, we can counsel also, because we can observe also during episiotomy time. First feeding is
dose,
happening in
yeah,
the labor room.
that will decrease the dose of analgesia also. She will
Yeah.
not require analgesia because she is in feeding the baby. Her momentum is diverted towards baby. It will be soothing.
And that time the bleeding also becomes less and the uterus contracts. That help us also. So
All the
first feeding
advantages.
should be in the labor room during episiotomy suturing, whenever it.
Even in cesarean, I keep the baby like this. Baby is kept like this. So for baby, it is same thing. Only the staff nurse or somebody, even our pediatrician holds the baby sometimes, if he's
Very
there.
true.
So all these things can be taught to the mother and of course our staff, so that they learn what to do even immediately after normal or cesarean delivery.
Sir, then is it all right to prescribe a formula feed in case of multiple pregnancies or twins?
Usually what we are told that breast milk is according to the need of the baby. If there are twins, there is naturally increased milk production is there. So we don't prescribe routinely to the babies formula feed. I have seen many babies who are 2.5 to 3 kg, they are prescribed breast milk.
The thing is that nourishment should be proper. Mother should be properly nourished because she has to give some extra work for 2 babies, 3 babies. But otherwise, the breast milk is tailor-made depending upon the number of babies, depending upon the weight of the babies, depending upon the requirement of it. And football method, yes, 2 babies, there is no partiality between male and female child. Both babies can be fed simultaneously by football method.
Yeah.
Yes, ma'am. Ma'am, is there any specific use for breast pumps and storage of human breast milk for mothers? Is there any specific guidelines or what the mother should do?
Shall I tell or anybody has?
Yes, ma'am. Actually, this question was for Dr. Suvarna, but she isn't joined, ma'am. She's in a cesarean section.
Yeah,
so you can
actually,
elaborate, ma'am.
Yeah, breast pumps, hospital grade breast pumps, sometimes are advised. But what happens if the mother is not taught properly? Sometimes speed of the breast pump can give trauma to the nipple and the areola. So usually what we prefer, we advise like a manual removal of breast milk, and we teach how to do manual removal. How it is easy. I have seen the mothers doing manually, and dhara niktar म्हणतात त्याला पण actually दुधाच्या धारा निघतात. I have seen mothers like this. But in some cases, if it is not possible, and we know a lot of stimulus to the breast, rather nipple or breast, then at times the hospital graded breast pumps are advised, depending, and the speed of the breast pump is adjusted as per the requirement. Otherwise, what happens if there is too vigorous removal of milk? Some only first there, unnecessarily the breast pump is applied. It will cause trauma to the mother. So it will not help otherwise. So if there are triplets, quadruplets, twins, and the pediatrician feels that the supply is less because the baby is not properly living because of prematurity, because the baby is IUGR. So milk removal is not proper, and because of that, milk supply is not proper. So in that case, breast pump is advised to remove the milk if manual removal is not possible. But first, we insist on manual removal. The mother finds difficult, then we advise hospital graded breast pump. And again, all these precautions, speed of the breast pump, size of the pump, all this mattered. We should teach the mothers how to apply all these things. But nowadays, what I have seen, misuse of breast pumps, because I know many of the working mothers, they want to go to the service station. So they feel that just remove the milk by breast pump and go for the working place. So this is wrong practice. They should go for manual removal. If they find difficulty of less milk is removed because of some stress factor, because of the time factor, in that case, both-sided breast pump can be applied, and same time, double milk can be removed. That will save the time. But I don't think mother should have shortage of time for baby. That's her priority. She should first think of baby, then workplace. So she can remove the milk manually in different stages. So different bottles or different dabba or packs can be there. Containers can be there in the freeze, one after another. Even room temperature 6 to 8 hours, the milk is stable at room temperature. 24 hours in freeze and refrigerator 3 months. So the removed milk can be stable even at room temperature for 6 to 8 hours. She can remove different containers step by step. In a single removal, it may not be possible to remove huge quantity of milk. but she can remove step by step at different times of the day. So that whenever she goes for working, the working hours, 36 hours or 8 hours, whatever, that removed milk can be fed by the person who is at home by taking all the precautions of boiling of that spoon and that mixing the milk so that only water or supernatant fluid will be given to baby and fat will be at the bottom of that container. Again, bringing that at room temperature by keeping the container in the warm water so that the temperature will be transmitted to the milk inside the container. All things we teach the working mother, so that they can join the work, and also the express breast milk can be fed by the other person in the family. But it's the second breast pump application should be numbered at second number. First, manual removal. If only in a human milk bank I have seen where they want large quantity of milk and in a less time, they try to apply breast pump to the PNC. So just to get for milk donation. But for a milk baby, for expression of manual expression of breast milk will be the easier method if taught properly before joining the service.
Thank you, ma'am. Ma'am, you can also elaborate about the Human Milk Bank. As you were the founder secretary, there would be no better person to answer this question, ma'am.
Yeah. Thank you, Monica, for the kind words. Actually, we had a lot of pioneer work in breastfeeding. I remember the days when rampant of formula bottles were there everywhere, not only in Maharashtra, but in India. But with constant hammering, taking education and awareness classes on breastfeeding and proper complementary feeding, after 6 months, we have won the battle. And at few places, it is still going on because there are different characters of the brain. We can't just force anybody. Whatever fits to our brain, we do accordingly. So what question we ask Human Milk Bank? I think mother's direct breastfeeding is the first thing. That is boon for the mother and of course for the baby, because it is a tailor-made nature's gift given by God, given by supreme power for the needs of the baby. But at certain times, if the mother is not alive, or mother is in a condition that she is not able to breastfeed the child, or the child is too premature, the reflexes are not developed to suckle and swallow. In those cases, the GIT or tube is inserted into the baby's mouth. In that inserted tube, the human milk bank or the milk from the mother, the baby's mother can be given. Or if not possible, the mother is not alive, dead mother, or the critical condition, she is in critical care unit. In that case, human milk bank can be given, donor milk from the human milk bank can be given to the baby. Of course, there are many things that the donor milk is first collected. After collected, it is screened. After screening, it is stored, processed, and then distributed. So there are different steps of distribution of donor human milk. And important thing is that it is for the not for the biological child. So if the biological child is there, she should try to breastfeed directly. But in rare cases, when it is not possible, then the milk from the human milk bank, donor human milk, can be given to the baby after all these steps. First thing is taking proper history of the mother who is donating the milk. Second is there are triple protection. We say triple protection. First thing is history. Second thing is screening on the blood test, all these things. Third thing is screening of the milk donated. So different tests are conducted, and the processed mother milk, processed donor milk is then given to the baby as per the pediatricians or healthcare providers requirement. All these things, why they are important? There should not be any commercialization of the donor milk. We have seen if there is extreme things are there, always there is a misuse of that particular thing. So people have started selling the donor milk. There are certain charges given by certain companies, 4,500 for only 300 ml milk. So they started selling the milk also. So in India, we have certain regulations are there. Even Human Milk Bank Association of North America, our national guidelines say that there should not be any commercialization of the donor milk. So if at all the baby requires milk because of the many factors, sometimes baby is too premature, sometimes baby is LBW, sometimes there is some GIT surgery on the baby. So for the healing of that GIT surgery, the human milk, donor human milk is given to the baby for the healing of the wound, intestinal wound or any GIT wound. In all these cases, it is like a trophic or is a nutrition of the intestine. So at certain cases, in some cases, it is just IUGR baby. Pediatrician wants to supplement mother's milk with donor milk. If the mother's milk is ample, she can just collect the milk and give to the baby by expression and feeding by that gastric tube or whatever pediatrician is doing. But in all cases, whatever we are advising, the milk for her own baby should be there. Then only the mother can donate the milk for another baby. So whatever donation is there, practically it is first for her baby and next for the baby to be given. If child in crisis having some need and the need is not satisfied by the mother's own milk. So direct breastfeeding, always advocate. Human milk bank is not substitute of direct breastfeeding. If at all there are certain conditions what I narrated previously, the donor milk from the human milk bank can be given to the baby to fulfill his needs. Recently, there are government of guidelines, Minister of Health and Family Welfare government guidelines that tells that every SNCU there should be human milk bank. So in Amravati, there are 3 human milk banks: one at medical college, second at government district hospital, third is a satellite center at private hospital. So there are some organizations like Rotary, they help to for the human milk bank. So all these things we need to know, because if our child wants all the advantages of mother's breast milk, and because of certain reasons, direct breastfeeding is not possible, or that the need of the child is more than what is getting from mother. A few rare cases of lactation failure, though they are very rare cases of lactation failure, but at certain times there is a difficulty of getting the milk directly from mother's breast. In that case, donor milk from human milk bank can be given to this needy child. Of course, there are many criteria: documentation, consent of the receiving parents of the receiving child. Consent is very important, because there was certain issue in some foreign countries. There are lot many cases of HIV transmission, so they stopped the human milk banks. But at presently, everything is scrutinized. There are certain national guidelines and foreign guidelines that govern the working of the human milk bank. Nowadays, we don't say human milk bank; we say Comprehensive Lactation Management Center (CLMC). It's not human milk bank, no. CLMC, Comprehensive Lactation Management Center. So it has broadened its definition. It has broadened, extended its functions. What were the functions previously? It has broadened everything. So again, it depends upon the city where it is practiced. In remote area, it is not practiced because freezing and all those things not possible. But in big cities like Nagpur, Amravati also, we have 3 human milk banks. It is practically possible with the help of yours. You can go for that. The first human milk bank there was in Austria in 1909, Vienna in Austria, first human milk bank. And in India, Sion Hospital in 1989, the first human milk bank was in Mumbai at Sion Hospital. And Armida Fernandez are these great people, Dr. Kubda sir, Dr. R.K. Anand sir, these great people, they were behind that Sion. Armida Fernandez madam especially, her hard efforts were there to start the human milk bank at Sion Hospital. And now there are 90 plus human milk banks all over India, and they work as per the guidelines given by India. And of course, we follow the North American guidelines, Human Milk Bank Association of North America.
Thank you, ma'am.
The
Yes, ma'am.
secretary started human milk bank. The concept of human milk bank, there was resistance from many organizations also. Why you don't advise breastfeeding directly? The first norm is advise breastfeeding directly, mother's own milk for her child. But at certain places, if the biological mother is not available, so instead of giving formula, instead of giving animal milk is for animal's child. हमें अपने child को human being बनाने का है, मानव बनवायचं आपल्याला, not animal. So animals milk for animal's child, human beings milk for human being, to create the values of human being. That means direct breastfeeding is number 1. If at all it is not possible, then milk from the human milk bank. This year's slogan, enabling breastfeeding, making a difference for working women. So at times, working woman, if not possible, she should try to express the breast milk. If the mother is not there, again the human milk bank donor milk can be given to them. In any case, breastfeeding, because breast milk has got many advantages over the formula feeding and of course animals milk. Thank you, Monica. Not audible, Monica, unmute.
Monica ma'am, are you on mute? Please unmute, ma'am.
Unmute kar. You are muted, Monica. Rajasthan, there was some training course. I was one of the trainers for the training. Till Monica joins, she gets unmuted. Acha zale. We were the Rajasthan. There was one person in Rajasthan. He started movement of human bill bank, and we had so many human bill banks in particular those 6 months simultaneously in different cities. And Rajasthan is showing least mortality, morbidity and mortality in case of infant. So that shows the huge advantage of human bill bank. Only thing is that it should not be misused or it should not be commercialized. Otherwise, like other things in India, any country, commercialization starts very fast. So we should understand the importance of direct breastfeeding. And if at all the baby requires breast milk, it can be given from human milk bank. Now the new word is CLMC, Comprehensive Lactation Management Center.
Ma'am, in China, they are selling breast milk online as a youth portion.
Yeah, but it depends upon their guidelines. Our national guidelines doesn't allow commercialization of the human milk bank. If somebody asks me whether I can sell the milk from my milk bank at my district hospital, I will say no. Because as such, district hospital's requirement is more. We don't get that much milk. Your own hospital babies will be given.
Such a picture.
It should not be sold because our nation doesn't permit that.
Ma'am, I had one patient who had come from USA. She was she
हमारा phone
had a
दो मैं-
preterm baby. And baby weight was around 2.5 kg, but maybe by US standard, it was a low birth weight baby. It was late preterm. So there, they did not advise direct breastfeeding at all to her. They told her to pump and feed. Until 8 months, she was pumping and feeding, and she came to me so fed up. And she
please.
breastfeeding, ma'am. She was
You
so
can understand.
fed up.
You can understand the misery of the baby mother when she.
Exactly.
It can give rise to healing, trauma to the breast. All these things, time is wasted. Indirectly, she can breastfeed directly, no? So I always give one example. Whenever I go to some workshop, no, they ask some Indian babies are like 2.3, 2.5, 83 kg. And the baby, the mother of the baby said, my baby is 3.2, 3.5 kg. And the baby was to that artificial hormone and everything. But I said, after a few years, you will understand the intellectual level of Indian baby who was totally on breast milk, direct breastfeeding, and the intellectual level of the top-fed baby. Though the baby looks like mota, but the brain is important. That's the reason why Indian go abroad in America. We can see many scientists who are Indians because still we follow the culture. And that shows the intellectual importance of breast milk. So even if they are like chubby babies, what about the intellect, brain, super brain? So for the intellectual, for everything, direct breastfeeding, mother's breastfeeding is very important. Just
Am I audible now, ma'am?
Yes, yes.
Yes, ma'am, you are audible.
Sorry, the other phone got hanged, so I had to join in from this one.
Hello.
Yeah.
Monica.
Is there anything else that we need to discuss?
Hello.
I was actually.
Hello.
To discuss the drugs which was being. Am I audible, please?
Yes, ma'am.
Yeah, drugs which are absolutely contraindicated in breastfeeding. Can we elaborate those? That is the only thing that we have left out. Anybody can answer, please.
okay. Dr. Saman, you want to advise? Dr. Tamboli, you want to say something?
Ma'am, you can start, ma'am. I'll add in the middle.
Yeah, okay. Actually, there is no absolute contraindication for any. Only thing, when the radioactive isotopes are given or some chemotherapy is given, then depending upon the half-life of the drug, the milk can be expressed before the half-life of that particular, because each drug has a half-life. So in that particular period, the maximum concentration of the drug in the breast in the blood, and that can get excreted into, of course, in the breast milk. But it depends upon the half-life of the drug. But for that, oh, baby, good baby, I can see the baby. Someone's baby, I think. Yeah, nice baby, huh? Your child, no? Your baby. How many months? How many months? Yeah, cute baby, yes. Breastfed baby, breastfed baby. So the depending upon the half-life of the drug, we can calculate at what time there will be maximum concentration of that particular drug in the blood, so that we can accordingly advise breastfeeding, and till the period is over, the express breast milk which was done before that maximum concentration can be fed to the baby by the mother or any other relative. So as such, only things radioactive iodine, patient is having some chemotherapeutic or some epileptic drugs, that is very little, it is not escalated to a much amount, but depending upon the timing of the drug, and the mother is admitted in critical care, that the drug is very important to save the life of the mother. In that particular case, the donor human milk can be given. Otherwise, there is no absolute contraindication, but there are, of course, certain drugs, certain chemotherapeutic agents, radioactive isotopes, that cannot be that can be transmitted via breast milk. But in that cases also, there is no absolute, what we say, adjust the timing of the drug, adjust the expression of the breast milk, so that the same advantage can be given to the baby by avoiding the ill effects of the drug. Generally, what we advise, whatever antenatal drugs were given to the mother, these drugs will be tolerated by the baby because she was given during antenatal period. So this is a general principle. But if we advise focus principle, focus treatment, the drugs which are, of course, are contraindicated are like chemotherapy, anti-cancer drugs, certain anti-epileptic drugs. If the half-life is adjusted, even the baby can be directly breastfed. But in certain cases, the mother is critical. We have to give donor human milk to the baby and avoid breast milk for that particular period. And there is maximum concentration of the drug because of the serious condition of the mother. Actually, this is a very big chapter on drugs indicated, contraindicated in the breastfeeding mother. But overall, the principles are same. Depending upon the concentration, depending upon the life of that particular half-life of the particular drug, breastfeeding directly or indirect by expression of the breast milk can be given to the baby. Generally, those who are on chemotherapeutic agents, they don't conceive, they are infertile. But if the diagnosis is there after the birth of the baby, already baby is breastfeeding, in that case, because the drug is too essential for the baby mother to save her life, the timing is adjusted as per the half-life of the drug, and expression can be done before the maximum level of the drug is reached in the blood, so that even if it gets excreted into breast milk, the breast milk may not be given to the child. In INH, in TB, we say that pulmonary coughs, even in that case, there are drugs given to the mother, and of course the baby is given that prophylaxis, and she has to advise rumal or hanky on the nose, so that it is not transmitted directly because of the droplet infection to the baby. In that case also, she can breastfeed. Even leprosy or any DDS drug is given. Any drug whichever is secreted into breast milk, if it is like life-saving to the mother or the taking care of the mother's health, it will save the baby also from that particular drug. So many times the question is asked, mother is having fever, whether she can breastfeed the child, we always answer yes, because whatever antibodies are there in the blood, they get transmitted to the baby due to the breast milk, and the baby is protected from that particular disease. So I always breastfeed the baby even if the mother is having fever. In TB, in leprosy, all these cases, unless there is some ulcer on the breast, areola or nipple, she should be advised to breastfeed, because water drug has been given to the mother, it will be secreted into the mother's breast milk, and that will protect the baby from that particular disease. Only exception is chemotherapeutic agent, certain anti-epileptic agents, and radioactive isotopes. These things we need to take precaution by adjusting the timing of expression, by adjusting the timing of the doses, and direct breastfeed.
Ma'am, I would like to add one thing. When we have a choice between two drugs, there are some drugs which are preferred over the other. So like for cold medication in flu that we're giving over the counter, they say to avoid phenylephrine containing preparations. And if you want to give a painkiller, to choose Brufen and paracetamol combination that are those are much better than diclofenac and other painkillers. And in antibiotics also, they say avoid fluoroquinolones.
Ranges, connectivity is gone. Diclofenac advice in antenatal period. No, there's we know oligohydramnia can be there because of the diclofenac use. So sir, we just give paracetamol if there is a headache or she's febrile. We just give paracetamol. That also
Yes.
320, not 500. Diclofenac we avoid because we know that can create a oligohydramnia. The amniotic fluid, bad effect on the amniotic fluid concentration, quantity. Certain drugs we avoid, but for breastfeeding mother, these are the general guidelines, whatever I told you previously. Dr. Tamboli,
Okay,
I
ma'am.
think.
Ma'am, I think we can come to the end of him. I would
Yes.
invite
Monica,
Vandana Madam.
can you please allow me half a minute at the end of the webinar? Because this is
Just
the
end this
consent.
with the competition.
Pardon?
Sure, ma'am.
So I would
Yes,
like to read out the slogan for which I got first prize. It was a slogan on breastfeeding, Breast Committee Workshop AICOG Kolkata 2022. The slogan was, I'm happy to share with you all. स्तन से है स्त्री की सुंदरता, पर स्तन्य दूध में है माँ की ममता। नन्हे की सुरक्षा और पोषकता के लिए यह है वरदान अनमोल। धरती पर केवल माँ का दूध ही है नन्हे का अमृत जल। Thank you.
Congratulations, Vandana. Beautiful lines.
Thank you. Thank you.
Heartiest
That's everything.
congratulations, ma'am. And
All us.
very, very true to this word. We have discussed this liquid gold in the last 3 hours. I think almost all the doubts must have got clear in the minds of all the obstetricians. Kundan sir, I would like you to share this recording.
Monica,
also so that even their doubts get clear. Yes, ma'am.
Only one thing we didn't cover this question. Many times mother comes to us and she wants to ask, whether I can breastfeed the child. The child is in a lab, 8 months, 9 months, and she's having then pregnant. She's pregnant for the second time, and she asks, and she starts formula or animal milk because she's pregnant. So that time the advice should be there. She should have extra diet because she has to care for intrauterine baby and this baby, the neonate, 1 year or 9 months old baby. But she can continue breastfeeding because unless there is some bad obstetric history, she has 3 abortions, 3 premature deliveries, and if the child has crossed 6 months or 9 months, then we can say already the baby is receiving top food, complementary food, homemade food. In that case, we can ask, okay, because there is a bad obstetric history. But if the history is good, she's having this child, 9 months old, 10 months old, and a 3 months intrauterine baby, she can continue breastfeeding because otherwise what happens? She deprives the neonate from breastfeeding. So whatever skin contact, emotional bonding, what are the immunity benefits to be given to the new baby, the neonate, he is deprived of the breast milk because of the intrauterine baby. So we should tell that the baby, she can breastfeed provided there is no bad obstetric history. But the baby already receiving top food because it has crossed 6 months, but the emotional bonding and many advantages of immunity can be given to this neonate even if she is having intrauterine pregnancy. Only thing, she needs extra diet for the baby in utero and of course the neonate to whom she is breastfeeding. Third thing, second question she asked, whether I can take oral contraceptives. I think it was not discussed. So we have to tell up to 6 months, no oral contraceptives because estrogen inhibits lactation. So we should advise either intrapartum CUT or during cesarean copper can be intrauterine device can be used by the mother. Even after delivery or during cesarean we can insert. There are certain injections which can be given to the mother, but no estrogen containing pills to be given because estrogen acts as the inhibitor of breast milk. So these things are very, otherwise what happens? This government national program is going on. Nobody cares for the baby. The packet is given to the mother. She comes for the vaccination clinic. Without thinking anything, she is given that package of oral pills. And then she will complain that all of a sudden the breast milk has stopped because of the negative action of the estrogen. So we must advise she should not take oral pills until 6 months. There are other contraceptives that can be used before 6 months, but up to 6 months, no estrogen containing pills should be given to mother. Of course, after 6 months, if she can avoid estrogen, okay. Otherwise, after 6 months, there is a role of complementary homemade complementary food plus breastfeeding. Even if the quantity gets little bit decreased, doesn't matter. But 6 months exclusive breastfeeding, even without estrogen containing pills. That advice we must give to each and every mother. Otherwise, the government program is misused for the breastfed mother before 6 months.
Madam, just please explain. Initially, we were used to discourage the feeding during pregnancy because it may stimulate and there may be irritable uterine action or she has a threatened preterm labor. So if she continues to feed the prolactin secretions, it may cause induction of labor. Is that true?
No, that's a myth. What I'm telling, not prolactin. Oxytocin will cause contraction of the uterus.
Yeah, oxytocin.
She may abort or premature. That
Abort,
was the fear.
yeah.
That was the myth. Fear, I should not myth, fear. But first thing, we should take proper history. If she is a bad obstetric history patient, like she's having 2-3 abortions, 2-3 premature delivery, like that. In that case, we should advise not to breastfeed or less amount of breastfeed during night time when she is sleeping, relaxed patient. If there is a bad obstetric history, she is aborting repeatedly, and this child and one child, then in that case, the child has already crossed 6 months. But up to 6 months, natural contraceptive method, what we know, 98.8% protection due to exclusive breastfeeding night and day. We know all these things. But after 6 months, if she conceives again, there is bad obstetric history, and that will cause stimulation, release of pitocin, oxytocin. Oxytocin will stimulate abortion or labor, what you expressed just now. In that case, we should not advise. If she's not having any bad obstetric history, we should encourage breastfeeding. Only thing, she needs extra diet for herself, for the neonate, and of course the baby in utero.
Thank you, ma'am. Thank you so much. Thank you, Walter Bushnell, for this academic event. Alka ma'am, thank you so much for your inputs. I would like to thank Mangal Rathi madam, Vandana Gandhi madam, Dr. Saman, Dr. Kundan Chopde, and the other panelists who have joined us. Thank you so much. It was a pleasure to be with you, and we have a lot of messages for all the delegates. That was a fruitful event. Thank you so much, everyone.
Thank you, Monica ma'am.
Thank you for the opportunity.
Thank you all the esteemed panelists. It was a very beautiful discussion during this breastfeeding week, ma'am. The inputs were very good, ma'am. Have a lovely evening ahead to all from Walter Bushnell.
Thank you to Mr. Ranjit Sahu and Sachin Amte. For
Thank
3
you.
hours, all OBGY, even pediatrician are there on the platform discussing breastfeeding and breastfeeding. The people used to do, what do you discuss for 3 hours? What's so much about breastfeeding? You came to know still the discussion is not complete.
Yes, ma'am. Yes, ma'am. Very
The
much.
2 questions that face my mind, I should tell. Otherwise, the 3 days we just spent 3 days for breastfeeding workshops and conference. So that shows the importance of mother's milk, and that shows the importance of the filmy dialogue. Agar tune maa ka doodh piya hoga to samne aa. You always remember that dialogue. That
Very true, ma'am.
It's very famous dialogue from our childhood till date. Agar tune maa ka doodh piya hoga to samne aa. That shows the strength of breastfeeding.
Thank
Very
you.
true, ma'am. Well said, ma'am.
Thank you all the delegates from the Walter Bushnell. Thank you, welcome.
Thank you.
Thank you,
Monica,
Vandana ma'am.
Thank you, Sachin.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you,
Good
sir.
night.
ma'am.
Yes, thank you very much. Thank you.
Thank you all.
Thank you,
Yes.
Monica, for involving me. Thank you, Dr. Pardesi, sir, Dr. Sujata Dalvi, madam, of course, Dr. Monica, for always involving me in such panel discussion, because she knows what work I had done since grassroots level, right from 1992, when the IMS Act was enacted. So thank you very much for involving us. Thank you, Vandana Gandhi, for wonderful poem.
Thank you, ma'am.
You know,
Thank
you are the poet, I know.
Thank you, ma'am. Thank you.
Yes, ma'am.
Thank you, Dr.
Okay.
Yeah.
Thank you, sir.
Sure.
Bye-bye.
Thank you all.
Sir, we
Thank
can-
you all. Thank you. Thank you. Thank you, sir.